No. I'm not the first speaker. Yeah, that's my job. Work for it.
Thank you. Okay. Thank you.
Okay. Yes, they want to use. So what's your password? Wi-Fi password is. We can put your use. My 50 is already.
I think it's here. Is that yesterday? Dr. Ajmer, he gave you some slides? No.
I should send you. This one. How to send you this?
Send me. I generate link to the.
Okay. If it is locked, it's there 6 or 2.
Anything?
So present it. So let it inside the car or let it inside the just I'm waiting for you. How we have the policies. The investigation must be done. Yes.
Thank you very much. I'm so sorry.
Our big
Unexpected. Well, we are glad to be here. Thank you very much. I will check my last year.
No, you try it first. Yeah, go ahead.
No, I'm not good. Can you check my laptop
Sure,
to make sure it works?
sure. Yeah. Okay.
It works?
Yeah.
Okay.
Yes. So the next presentation, I just yeah, what yes. I think it's 2020. 2020 is the ISGE training. Which one? 2020 is the ISGE training. They don't know the other one. This one. Yes. Yeah. Yes. Yeah. This one. Only one? Yes. Thank you. Yeah. Sunday.
Or I send you.
Already he said, Dr. Asmin emailed to email.
No, you didn't meet Sunday.
Just now he said.
Why just now?
Then he said.
Bismillahirrahmanirrahim. Assalamualaikum. Yang berbahagia Profesor Dr. Amir Robotic, President of Lincoln University College, Dato' Ambassador Dr. Muhammad Yusufin Abu Bakar, CEO of Lincoln University College, Professor Dr. Hafizah Chair Hassan, DBC Academic, Lincoln University College, Professor Abdullah, Deputy Dean, Faculty of Medicine. Our speakers and distinguished guests. Professor Dr. Rashad Pasif, Department of Obstetric, Gynecology and Women's Health, University of Louisville School of Medicine, USA. We applause for them. Associate Professor Dr. Sandeep Shreka, Associate Professor, Kikihar Medical University, China. Dr. Jianming Song, owner of Mega Home Medical. Mr. Doxin Liu, Overseas Sales Director of Yunnan Yonghui Medical Technology. Mr. William Y. Dongzu, Director of Polycan Health Center, Canada. And Mr. Ji Yubing, CEO of Secure Medical China. Welcome to all of you. Ladies and gentlemen, we are going to start off our event with national anthem. Ladies and gentlemen, please rise.
Tanah tumpahnya darah.
gentlemen, please be seated. Good morning again, ladies and gentlemen, distinguished guests, and esteemed medical professionals. Good morning. Welcome to today's highlight anticipated seminar on advances in laparoscopic and robotic surgery, organized by Faculty of Medicine, Lincoln University College. My name is Amisha Mazlan, your MC for the enlightening event. It's an honor to be here among such a knowledgeable audience to witness the transformative progress in the field of surgery. Without further ado, before we embark on this journey of innovation and excellence, as the rightful start to this morning's ceremony, please welcome Mr. Hassan Al-Basri to recite the prayer.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين وعلى آله وصحبه أجمعين. Ya Allah, Ya Rahim, praise be to God, the Lord of the worlds, peace and blessing be upon our Prophet Muhammad sallallahu alaihi wasallam and his companions and for those who followed his example till the judgment day. Allahumma ya Allah, on this blessed morning in conjunction with the seminar, we beseech thee and grateful towards you in favor of all infinite blessings to us, your humble servant, to live in safe and prosperous life. We seek your blessing for flawless progress of this event from the beginning till the end. We seek your guidance to stay clear of events that would be detrimental to the progress of this event. Ya Latif, Ya Rahman, please bless us with your tawfiq and hidayah. Please guide Lincoln University College to greatness, peace, glory, and prosperity in this world and the hereafter. Grant us with a valuable knowledge that will be beneficial to mankind in order to gain your mardatillah. ربنا عليك توكلنا وإليك أنبنا وإليك المصير ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار صلى الله على سيدنا محمد وعلى آله وصحبه وبارك وسلم والحمد لله رب العالمين.
Thank you for the dua recitation. Ladies and gentlemen, we are going to continue. We'd like to invite Yang Berbahagia Dr. Amir Bomi, the President of Lincoln University College, to deliver his brief opening speech for today's seminar. Please welcome.
Assalamu alaikum and very good morning to all of you, especially our guest, Professor Dr. Rashid Prasid, MD, PhD, Department of Obstetrics, Gynecology and Women's Health, University of Louisville School of Medicine, US. Associate Professor Dr. Sandeep Srestha, a good friend of us. Dr. Song, MD, owner of Mega Fu Medical, where I was supposed to visit last month, but couldn't go. And Mr. Vine, Mr. Liu, Mr. William, and Mr. G, Mr. William, Mr. Bian cannot be here. Unfortunately, they had to go back for some reason. And all of you, my pleasure to be here today with distinguished guests. Now, I would like to give you a little hindsight what we are heading to. Unfortunately, Prof. Jarina Dean is not here today, though she is online. We have the medical school, we have dental school, we have pharmacy, we have physiotherapy, we have nursing, we have medical labs. We are lacking of medical center where our students, our faculty members can have practical experiences. With that, what we have done, we have removed all the lab facilities from this building. We have taken to our Wisma Lincoln, and that Wisma Lincoln slowly and steadily we will convert into a medical center, the beginning. Now, every beginning, we have a real journey. And on that, I spoke our good friend, Dr. Sandeep, and he has been a good friend to us all the way from Chichir Medical University. We have a good collaboration, and ever since we started medical school, our founding dean, Dr. Gani, visited Chichir Medical School, and we are doing bits and pieces. And this is another important milestone of collaboration between Chichir University in China and in Malaysia. Dr. Sandeep has been working with our Canadian guests today many years. So he said, sir, let's start with this. And we assure you, all of you, it may look like small. When we started Lincoln, it was really small, but we have grown bigger, including top 3 in Malaysia, which some of the government universities, some of the private universities could not achieve. In the world, you know, we are 248, that ranking, which very popular universities in the US, UK, Canada even could not have that kind of standing. Now, the standing, educational, it's not the building. Educational, it is you, the faculty members, you, the expert, you, the student. It is not the building. It is not the furnitures. It is not how it looks like. One of the famous university in India, started by Nobel laureate Rabindranath Tagore. And he started a university. He did not have any building. He started under the tree. Until today, that tradition goes on. So the educational institution quality does not depend upon building. In this country, we have many universities, have big building, but they are nowhere in ranking, nowhere in internationally popular. So, ladies and gentlemen, it is you who are inside this room. It is you who are online. They are the main factor of putting Lincoln ahead. And I'm proud of our faculty members, our students, and definitely one day, the guests who are there, we will start our medical center along with their intervention, and you will see one of the best medical center in the world. I appreciate Dr. Song, that how much he takes the pain to come here, traveling from Canada all the way. And I was supposed to go and visit him, but I could not. My sincere apology, but definitely I will come. But he said, okay, if you don't come, I will come. Look at that, how much interest he has on us, how much friendship he has with Dr. Sandeep all the way. He brought very genuine professor in OMG. And I appreciate, though last night all of you had real trouble, and Visalini and Amer, Jairi, 3 of them were very patient to receive them and make sure they are comfortable. Anyway, thank you very much. I appreciate, and we assure you, these people are eager to listen to your practical experiences, and we will move forward, Dr. Sam and Professor. Thank you very much, and let's listen. Thank you, and God bless.
Thank you, Professor Doctor, on the speech. Yes, yesterday was a new, but I really hope today is going to be a new day for you, and it's going to be a great day. And let's share the knowledge among our participants. Okay, so today we have gathered here to explore on the remarkable advancement in the laparoscopic and robotic surgery. Okay, two cutting-edge disciplines that have revolutionized in the field of medicine. Our distinguished speakers, all experts in their respective area, will be sharing their profound insights and experiences throughout the day. So I would like all the participants to, focus and take a look what is our speakers can share with all of you. Okay, next, I would like to invite Professor Dr. Abdullah, Deputy Dean, to present and brief about our next speaker. Please welcome.
Thank you very much, Amir. Assalamu alaikum and good morning. Today we will start our, for example, laparoscopy and robotic surgery, and we will start with the first speaker, Associate Professor Dr. Sandeep Shestre. He is the Associate Professor of Bihar Medical University in China. He has a visiting professor at Lincoln University, visiting professor of Swallenbok University in Kyrgyzstan, more than 15 years of experience in his work in neurological field, attending more than 30 national and international conference related to the surgery and healthcare. And he also area of specialty urinary blood cancer. He's working and awarded top 101 foreign talent and A-grade foreign expert in hearing prevents China. He is the advisor board member of International Journal of Cell Science and Biotechnology. He is also International Journal Multidisciplinary and Current Research and editor of International Journal of Multidisciplinary and Scientific Emerging Research, and also board members of International Journal of Current Engineering and Technology. More than 20 publications in top and ranking journals. So welcome to our Professor, Associate Professor Dr. Sandeep.
Good morning to everybody. So before my slide, so I'd like to thank the Lincoln University College and all my colleagues over here and all the leaders who give me the opportunities and all. So especially today's talk about my presentation is not exactly about laparoscopy, but this one is one animal study that I have done, and it's still on the research base, so it's still not completed, but it has started on 2013. So it's been 10 years. So there was some results came, and I'd like to share with you all. So, and maybe my next other speakers, so they were going to talk about the laparoscopic and all. And maybe in the afternoon time, maybe there will be some medical technological companies are here, so they will show the laparoscopic machines and all, so how they are working together with us. So, and before we came up here, so we were in Nepal, so we performed some laparoscopic surgery, especially in women, like we have done a total hysterectomy, and it was a very good experience. And maybe in the future, so we will also start the same kind of program in Malaysia as well. So without any delay, so I will start my short presentations that the other speaker will get more chance to talk. It's okay. Okay. Yeah. So whatever my topic over here is the study of bladder cancer, is the regarding the mechanism of melatonin enhancement of the curcumin anti-tumor. So I'll just shortly I'll talk about it. So mainly it has some methods and materials, and some results are there. Before we'll start, so I'll go through some bladder cancer about some backgrounds. So whole in the like bladder cancer ranks the 10th of the world cancers, with the estimated of more than 500,000 new cases diagnosed, and caused the more than 200 deaths in 2020. So this is also one of the leading cancer in the world. And in the five-year survival rate, a patient with invasive and metastatic bladder cancer is still very low. So because of this, so we do the surgery, chemotherapy, and the radiotherapy, and as well we do some immunotherapy. So what is next? So these all we are doing. So now new treatment exploration is very important. So over here, thank you very much. So over here, because as I'm also in the China, so I have used some traditional Chinese medicine combinations. So I have used some methods. I used like some MTT assay and polluting formations and all. These all are the process. So these all are the process I have used over here, like immunofluorescence staining and the Western blotting, and also the RT-PCR and the pull down assay and flow cytometry and the animal studies. So most of us who are over here maybe will be much interesting in the animal studies, but I'll just go through it shortly. So by using this method, so here the melatonin and curcumin. So melatonin is it is secretion from our pineal gland, and its combination with the curcumin. Curcumin is the one traditional Chinese medicines, or especially is the family of the ginger, if we talk about the layman term. So this is the normally in Malaysia also we use mostly like a turmeric and all. So this is the family of that. So with the combinations, so it has enhanced the inhibitions of the cell proliferations. So we'll go to the few steps we'll go, and while doing this study, so along with this melatonin and curcumin, this combination enhance the formation of inhibition of cell cycle arrest and invasion, and as well after what we have done is we have prepared the one nude mice. Okay, so in the first to end, I'll explain first. So we have arranged one nude mice. So over there we have applied some tumor inside that nude mice. After the generations with the apoptosis, with the nuclear factors kappa B and translocation binding of the COX-2 promoters and all. So we have created the tumor over there. After the tumor, so we have made use some cell lines. After the cell, we have used some different kinds of cell lines. So here the T24 and UMUC3 and the 5637. So with the combinations of the melatonin and curcumin with these cells, so we have found that the tumor size get decreased, but alone in the melatonin will get decreased the size, but together with the melatonin and curcumin has mostly it is get decreased is size. I'll show you in the next slides and all. So like as and the human T24 and UMUC3 and the 5637 cell were treated with the melatonin and the curcumin alone, or their combinations at the indicated doses. And also we have done the MTT assay, and we have used at the DMSO. There is determined for the we have used for the reference group with the cell viability set as 100% as well. So if you can see over here, which one is the pointer? So if you can see over here, which one is the pointer?
Yeah,
pointer. Yeah. Okay. So over here, we can see there's a cell proliferations are there comparatively. Like if you see these slides, so it will be more clear on it. So here the control, here's the melatonin and curcumin alone. So comparatively, if both we have combined with this one, so there is a cell proliferations are there. So here the colony, there's the cell cycle, and it is a colony formations are there. So here also is the control group, and in this cell, so especially in T24 cells, and especially in the UC3 cells. So is the combinations. So it is as the dose has increased, so here the colony formations are there. Okay, and it leads for the inhibitions and cell cycle arrest. So I'll not go too much detail on it because I have to give the most time for the some laparoscopic, whatever we have the robotic surgeries and all. So I'll not go that much detail about the cell migrations and invasions are there with the combination of the melatonin and curcumin and all. And also there is the we have done the combinations. It has inhibition of a cell migration and invasions are there. So over here the melatonin and curcumin combinations that promoted the cell apoptosis inductions. So these synergistic inhibitions of cell proliferation induced by the combinations of curcumin and melatonin that is associated with the enhanced activations of the apoptosis pathway in the bladder cancers. And that one is one of the facts analysis we have done. So here the percentage we have found that the result shows that the treatment with the curcumin and the melatonin with its respective dose alone for the 48 hours is induced the 38.8% and 29.4% respectively of the cells became the apoptic in the T4. So we have created the some cancers or tumor in the animal, especially the nude mice. And so we have done so we have performed the immunofluorescent imaging IFI analysis to confirm the localization of the cytochrome C and mitochondria to determine whether melatonin could sensitize the curcumin-mediated cytochrome C release. So here, especially in the meanwhile, the protein level of cytochrome C was also detected in the cytoplasm, where the mitochondrial fractions was isolated. So okay, so over here with the treatment with the curcumin alone at the dose of 5 and the 10 slightly inhibited the COX-2 protein expressions, and while the combinations treatment with the melatonin significantly reduced the expression of the COX-2 in these all the cell lines. So I have taken the cell lines is the T24 and UC3 and the 5637 cells. That is especially for the cell lines I take for this research. Also, this is the promoter, COX-2 promoter. So I'm going a little bit quickly, okay, to come to the little bit in the especially over here. Here the combinations of the curcumin and the melatonin is inhibit the tumor xenograft, is a new graft growth in the nude mice model. So as we can see in the pictures over here in the control, this is the tumor we have created in the nude mice. So after we have used the melatonin and curcumin in the specific dose in all the cell lines, and after the combinations with the melatonin and curcumin, the tumor reduced in the very small size. It is even though less than 0.5. So I'll give you a little explanations on it. So over here, the melatonin and curcumin combination inhibit the tumor xenograft growth in nude mice model based on the results from in vitro studies for the investigate the potential of the combined treatment with the melatonin and curcumin for tumor growth and its inhibitions in the human bladder cancer and in the xenograft mouse model. So both the tumor volume and the tumor weight were inhibited by the melatonin or curcumin alone. And however, co-treatment with the melatonin and curcumin together dramatically enhance the growth inhibitions of the xenograft or the new graft as a compared with the treatment with the curcumin alone. So in addition, the combined treatment did not. So this is the one of the best things that I found while doing the this experiment. So there is the combined treatment did not affect significantly because they didn't affect any significantly the body weight of the mice and had no other significant signs of the acute or delayed toxicity were observed in the mice during the treatment. So this is but this one is I've done in the especially in the bladder cancer, but still it is going on for the even in the ureter and even in the prostate and also in the kidney. So is still going on and in the different cell lines and all. And also we have, this is the, after we make some slides and all in the, so over here, we can see the growth in the, so there is, especially in the combinations with the melatonin and curcumin. So basically, we have done the HE staining also in the all cell lines, and mainly whatever the results came to us is we have in the conclusive part, what we have done is like the melatonin is a synergize the effect of curcumin to inhibit the growth of bladder cancer, both in vivo and also in the vitro. So we identify the underlying mechanism that is the combined with the effect of A and the melatonin on bladder cancer cells are achieved through the simultaneously targeting cytochrome C or caspase in the COX-2 nuclear factor kappa B or the kappa B signaling and all. The combination treatment with curcumin and the melatonin on bladder cancer growth inhibitions can provide the strong evidence for such a combination treatment might potential to become an effective way in the bladder cancer therapy. So after I have done this study in the melatonin and curcumin, so it may help in our research thing in the further study. So this one is also a publication has done as well. And there is before I go for these all things, so I have done lot of reference papers. And before that, okay, so about these all are about my study because I didn't elaborate detail because there's a time I want to make a time consuming because somebody will tell that there is a laparoscopic and somebody came with some animal study. Yeah, maybe somebody will want to kick me out also. So that's why. So we want to. So whatever the studies also I am doing some study even in my university in China as well. There's a Chichar Medical University. So here there's some there's the main teaching buildings and the main gates are there. These all are our administration's building, and this is the whole area of the Chichar Medical University, and there's a teaching buildings and all. So as our president sir also told, because buildings because we need in China because we have a huge populations. So because we have to accommodate the persons. So, but still we are learning with the associated with our Lincoln University College, and these all are some pathological buildings. So still we do our study over here, and also there is some students, and he's from India as well. So we are doing some studies and all. So these all are the lab place in the pathological lab. We do some study. Okay, thank you very much for everybody.
Thank you very much, Dr. Sandeep, for your excellent research and study regarding the different type of materials. So now we'll start with the second speaker, Professor Dr. Jinming Song, and education about Professor Jinming. He is an MD from University of Fujian Medical University in China, 2 Master of Surgery, one from University of British Columbia, Canada, another one from University of Chengji University Medical School in China. 1 year of cardiac surgery, and also complete 3 years family medicines and emergency medicine. Recently, he received the first year of President's Award. He's American Board of Family Medicines, College of Family Physicians of Canada, and also fellow of the College of Family Physicians of Canada, members of American Medical Association, Canadian Medical Association, College of Family Physicians of Canada, and Doctor of British Columbia, Assistant Professor of Origin Health and Science University School in United States, and also clinical instructor of the University of British Columbia. Also, he have another position, for example, like clinical practice in emergency medicines. He have also practiced emergency medicine in Oregon and Washington State University. General practice in British Columbia, Canada, and in 2008 he he participated with the U.S. Olympic team in the Beijing Summer Olympic Games. Also, he's awarded as the director of the International Society of Gynecology Endoscopy, China. Now we'll start with our second speaker, Dr. Jinming.
Thank you so much. And thank you so much for it's my pleasure to be here, and thank you for President and also University of the Lincoln University School of Medicine to invite our medical team here to be presented, to be the International of the Society for Gynecology Endoscopic. We'll be very happy to talking about the possibility to bring the ISGE, is called International Society Gynecology Endoscopy, to bring here to collaborate with Lincoln University to set up maybe training center here. So I'll be get a very briefly introduction about the ISGE and also what we have done in international, in global, and also what we have collaborated in China. I'll be also talking about, because we did try to invite the president to go to Canada to visit one of the first, digital hospital of the North American called Humber River Hospital. Will be also briefly introduction what they do called the digital hospital. And anyway, I'm so sorry I did not really, because last night I'm coming here very, very late, so we did not change my title and anything. So I'll be very briefly to go back to here. So I'll be very happy to talking about the ISGE. ISGE is one of the biggest international society, especially in the minimally invasive gynecology surgery. So they set out in the 1989 by the multiple distinguished, the minimally invasive gynecology surgeon from the US and North American, from the global. And so our goal is actually try to be seen for the training, and also to do like the hand-on training and light surgery training, try to net global minimally invasive gynecology surgeon to do the standard surgery, especially how to do using the laparoscopic or robotic surgery. So this is something that we also have very good standard guideline to let the doctor to be master of the minimally invasive gynecology surgery. So anyway, we did been to China. We also set down now this society have more than 100 from 100 country society of the minimally invasive gynecology. They join this ISGE. We also have more than maybe 3,000 the membership from the ISGE. And my original idea introduced me. Actually, originally I'm from China. I get a medical school from the Shanghai Jiao Tong University Medical School. I do the 5-year general surgery training in Shanghai Ruijin Hospital, one of the biggest hospital in Shanghai. Then I go to the University of British Columbia to do my Master of Science in Surgery in Vancouver, BC. Then I do the 1-year cardiothoracic surgery training in Ottawa Heart Institute. Then finally, I cannot be an attending surgeon because it's very competitive to be a cardiosurgeon in North America. And so I go to the Indiana University, IUPUI, and Indiana University, Purdue University in Indianapolis to do my family medicine and emergent medicine training. So I finished my resident training again in 2006. Then since then, I practice in the emergent medicine in in the northwest United States, especially in Washington, Oregon State. I also do my, also practice in British Columbia in Canada. But I also very interested to do the, international collaborative because originally I'm from China. So I have a very good relationship with a very distinguished Dr. Professor Paya Percy and other distinguished minimally invasive gynecology surgeon in ISGE. So we try to bring the ISGE training to China. Then we have a very big collaborative with the Chinese medical school and Chinese medical center. So this is some of the training center of the ISGE. This is one of the training center ISGE in Italy. Then this is actually ISGE training center in South Africa with the South African Medical School. This is actually they have training center in the Caribbean, in University of West India in Jamaica. And then this is actually something talking about how the ISGE to do the training for MIGS surgeon. Then we also have something like the training model to how to get training for the young surgeon. And this is something like the model, like using the cadaver training. Actually, Dr. Paya Percy is the first, the minimally invasive gynecology surgeon in the world to begin in the first training using the cadaver to do the minimally invasive gynecology training. I'm sure he'll be talking a little more about this. So we also training because if you like to be a good surgeon, first of all you need to get a good hand skill and standard how to do the suture, how to do. So we did have also using the boss trainer to do the training. This is some of the sample how they to do the minimally invasive gynecology training. So this is something like the model to do the training, and also they can do the training in the the hand boss training. So another one, they also using the virtual realistic training to do the training. This is like they teaching how to do the laparoscopic cholecystectomy. And also this is the training how to do the to stop the bleeding for how to cut ligation of the blood vessel. So they did also have now this is more advanced the training actually called robotic surgery. They're using the robotic surgery to do the many assisted the minimally invasive surgery. So also this is like something like robotic surgery training. And also they did have using the something called virtual related VR application to do the hand-on training in the model. But at the same time, we also go to the OR to do the some of the training. This is any different kind of training model. But most important, actually, we did do the called hand-on light surgery training. That's very important. That's why in North America they call standard resident training, using the attending surgeon to teach the resident how to do the to be a good surgeon. Like they do the multiple case in a day. So this is actually we did do the some light surgery in different country. But I'll be showing more picture in the next several slides. And actually we've been to, this is some of the picture we've been to an ISGE faculty member to go to China. We have a surgery with the Chinese the MIGS young surgeon. That's also one of our faculty. We've been to China in different university, hospital, and biggest the medical center to Chinese surgeon with the faculty from ISGE to go to the hand-on training. That's also some of the picture I'd like to share with. Okay, well, actually, ISGE not only do the very good hand-on training, also do the lecture, but we also have a very wonderful the conference. Each year we have a multiple conference in all over the world, and we also have an annual conference. And this is actually the one this year. The conference will be in Indonesia, and I'm sure will be in the next week. In the Bali, in Indonesia. We also go to different country. This is the one the training we do in the in Jamaica, and also training in Hungary, and also this we also been to the in Morocco, in South in African country. We also been to the in Croatia, and also this is the training in the Laparoscopic in Hungary. This actually we've been to in the Croatia in the Arcadia in 2021. So anyway, and we also have a very big board committee, to try and every maybe month do the conference, either like teleconference or either like in personal conference, to talking about how to make standardized training to be more guideline to improve our guideline to get standard training for the young the surgeon. And we also have this is the conference we done in the lecture last year in Morocco, and this is actually something like we in the this is something like the from the different company manufacturer, they made the hand-on training training box to teach the surgeon how to do the train to be the good surgeon. So this is actually we just done the one light surgery training in Italy, and just 2 weeks ago. And we also been to the China nearly every year before the pandemic. Several times we go to collaborate with Chinese Society of the OBGYN or the minimally invasive gynecology surgery, and we did do the many conference and also do the night surgery now. That's the Dr. Paya Pasi have a surgery with Chinese in the woman surgeon. That's just something picture to share with our here in the audience. So we also get a very good lecture to do to teach how to do like good surgical anatomy, especially in the the pelvic anatomy. And also we have a training the Chinese like the surgeon to be faculty to be the ISGE faculty. So anyway, this is a very briefly introduction about the total step 3 ISGE to do the training for the like to be a good minimally invasive gynecology surgeon. And this is a very briefly introduction about phase 1, phase 2, and phase 3 training program. So it will be interesting to see whether I can bring this type program in Malaysia, and also to collaborate with the Lincoln University. And this is the I did mention some of our training center in global. So this is actually I set down a very good training program in China, talking about the guideline how to do training, and also the proposal, but that's in Chinese. So I'm sorry, I will be go to quickly scan it. So this is something that we try to set down a very modern hybrid OR. So anyway, I'll be very happy to share with the called the digital hospital. That's why in North America, this is the first digital hospital in North America. Actually, I tried to invite the president to join. Actually I just been revisit this hospital about 3 weeks ago. And this is the first one actually is in in Toronto, Ontario. Is Ontario government spent about like 2,000 million Canadian dollars to build this hospital in 2016. So this is the model and the picture of the hospital. So everything they do inside, they also using the so many good, and they try to set to window. All this window can be very good to absorb the solar power. So they will be very good to say that, like the electronic power, and on the window is very good, like good, design. So this is one of the sample of their truly, the patient unit. This is another one good, the patient unit. Then also this is actually for the, PICU. Then this is something like the model of the, so the patient when they stay in their bed, they can know, just go to screen, they just touch the screen, they can know what kind of treatment they have will be given to him or her. Then also if they have something demanding from the nurse or either to require to talk with the doctor, they just touch the screen. Then they can find out that, they are attending and can find out what kind of treatment. Then they can also to know what they will be treatment program for them. So this is their very good, the OR. Now also another OR we actually have a very good imaging study in the OR can quickly to get a very good diagnosis before a peri-operative. So they also very good one program that it's called, this actually now is more than 200 hospitals now in North America try to learning. This is called a central control program. That's mean they will be getting all patients, vital sign, all other lab. They'll be collecting together, then everything information from each individual patient. They'll be send, the information to called central control station. So this is central control station. They have maybe more than 20 nurses or some of the IT people they working together. So they're using the patient, vital sign, the lab. So for example, if one patient just have surgery, so if the vital sign is talking about, this patient heart rate now is about more than 120, blood pressure is dropping, the hemoglobin dropping, then they can alarm. Then they can, the central system can send the information to alarm the nursing station, then with the patient, where the patient stay. So the nurse in the floor, they can find out that can be, because understand you in the hospital, many nurse and the doctor is very busy. Sometimes they can make mistake to, do not earlier recognize patient, like very, very alarming, warning, vital sign. So the central system can be very good to give the, doctor and give the nurse immediately, pay attention about patient information. Then can be immediately, for example, like this patient blood pressure dropping, heart rate increasing, and also hemoglobin dropping. That's why I need to worry about post-operative, post-surgery hemorrhage shock. So they can be getting immediately, care. So this also have another one good system. That's why, because they have a doctor, because in North America, we have very, very shortage of any kind specialty, any kind doctor. So the surgeon will be very busy. They don't need to be, for example, this patient has surgery. The surgeon don't need to be stay in the OR, during the patient to do the anesthesiology. So the surgeon can still to do something other. They'll pay attention for other patients, but they can know what's the status of their patient now. Because, for example, this patient already in the OR, they sent to the OR. So the surgeon, they have their watch in their pocket. They can quickly find out where his patient location now and what's the status of his patient. For example, the patient just completed the anesthesia and then patient is falling sleeping now. Then the surgeon can go to OR to beginning the surgery. That's why it can be much save the time of the doctor and also make the physician to working more efficacy. So also they're using this is called the transfer information. That means the doctor order the prescription or the medication treatment for the patient. Then they will be send the information to the pharmacy station. Then pharmacy can, after the confirm the prescription is correct, then they can go using this transfer system. That's why medication can go to this transfer arm to send to the patient the unit. So this is something like the system. So also another one, they also call digital hospital. So everything delivery, for example, equipment and also ship or anything OR material, they will be delivered by this the machine. Robotic machine is not delivered by human staff.
Thank you very much, Dr. Jibing. And Dr. Famia, you want to tell a few words?
Thank you, Dr. Sun. I appreciate what you have said. I would like to mention all of you, the students, the faculty members. Dr. Sun has proudly said that he comes from China originally. His first degree from China University. And that university degree is not directly getting to the licensing of North America. He has gone through many examinations, and today he is a world famous surgeon. This is why one of the reasons I have invited him to come to inspire all of you. Though Lincoln Medical School may not have direct access, but with this medical degree, you can be world famous medical doctor as well. That's the living example in front of you. And I'm very pleased to know, I know that he has set up international organization. He could have stayed back in Canada and make money, enjoy his life. But why do you think he is going into all these international countries and setting up this training at the same time conducting the modern technological? That's noble cause for the society. As an educator, as a medical doctor, you have a responsibility towards the society. So that's why he has set up this international organization and taking all over the world. And all of you, the faculty members, the students, must learn from him that humanistic character need to be implemented in the society. And that is what all about Lincoln University College. Creating an impact in the society. That's most important. And that is what Dr. Song is leading this team and see how much can create. It's not the business. Of course, if you do not make money, how do you run the organization? So before we could think it's a business, understand the inside meaning of this initiative. Last night, by the time he got into bed at 1 o'clock, and today he's here, and tomorrow he's leaving. Why he's doing that? And that's what I call ethical entrepreneurs. Entrepreneurs that want to do something. Ethical meaning that how many people are going to be benefited by this kind of training surgery. And I humbly request my faculty members and the students learn this part of hidden human character in Dr. Song. And I hope all of you should try to imitate this kind of character, and you will find yourself that you will be able to contribute. My friends, I always say, we human beings are tourists in this world. We all have to leave this world. But before leaving, let's do something for the society. So when you leave this society, people will remember us. And I appreciate, Dr. Song, that what you have been doing with my friend, Dr. Sandeep, and your team, I look forward to working with you. Thank you, Dr. Song. Thank you.
Thank you very much, Dr. Ramian. Now we announce about the third speaker, Professor Dr. Rashad Basic, Department of Obstetric and Gynecology at Women Health, University of Louisville School of Medicine. He started his journey with medicine in 1969 with the MD from University of Sarajevo, former Yugoslavia. And after that, he started with residence, internship, and also Master of Surgery from Postgraduate School of Sarajevo in 1980. Then after that, he started with a PhD by research of from also say University of Robotic University School of Medicine in the United States in 1987. Another PhD in 1990 between the collaboration between Louisville University and Sarajevo University. Also, he have a lot of achievement. He got his obstetrics in 1992 in Louisville University, assistant professor in 1985 from Sarajevo University. In 1988, visiting faculty in the Louisville University in Kentucky, United States. In 1992, he became interim instructor in the Department of Obstetrics and Gynecology, and also assistant professor and associate professor in 2002. We have a lot of position as a physical investigators in 1987. In 2001, he's the co-director of Forum of Advanced Gynecology and Endoscopy. In 2006, he became director of Section of Obstetric Gynecology and Endoscopy in the Louisville University, Kentucky, United States, presenting directors of Fellowship of Advanced Gynecology Endoscopy in 2013, and 2010, director of AGGL Fellowship of Board of Minimum Invasive Gynecology. Board, he have different board, for example, Yugoslavia in 1982, Kentucky in 1994, until now, Indiana in 1995. More than 14 professionals membership and activity, more than 19 honors and award winner, head of the many committee and also administrative, more than 13 journals, editor and board. More than 14 course development and also directors, more than 160 abstract and presentation for oral presentation, more than 190 international presentation, 100 live telesurgery and publication video books, like 51 paper review and 17 non-paper review articles, 67 abstract, 34 video abstract, posters, 37 book chapters, and 5 book edited. Now we'll start with Prof. Rashad.
Thank you very much. This should work. Assalamu alaikum. It is my great pleasure to be here in Kuala Lumpur. This is my first time in Malaysia, and I'm very grateful for the president of Lincoln University for this invitation. For you that you did not know, probably most of you should know that Abraham Lincoln was one of the most famous US presidents who actually fought for human rights against slavery. And he's one of the greatest presidents that they had or we had in America, since I am American citizen now. So another thing that Mr. President said today was very interesting, and we had a very similar saying in Bosnia. We have our saying said, "It is not the cage that sings, it's the bird." So it doesn't matter for what your surrounding is. The most important thing is what kind of personality you are, not where you come from, but what you are capable to do. And I'm very happy to be here in this environment where I can share with you some of the things that I have done. How many people in the audience are just medical doctors? I know there are like all kinds of profiles here. Can you raise hands? Oh, you don't count. All right. So I have tried to make my presentation applicable to other people that are not just doctors. I don't want to bore you with the medical stuff. So I will try to be a little bit more broad. And however, I will talk about endoscopic surgery and in general about surgery, to show you the history of surgery, where we have been and where we are going when it comes to medicine and surgery. Can we turn off these lights so it'll be easier? I come from University of Louisville. I'm actually, as they mentioned, I was born in Sarajevo, Bosnia, ex-Yugoslavia, and due to the war in Sarajevo, I moved to United States. I ended up in Louisville, Kentucky. Louisville, Kentucky is a city that is about in the middle of America. It's about 1 hour by plane south from Chicago. And it is the place where they have most famous horse race in the world. It's called Kentucky Derby, that everybody comes there. They have a University of Louisville, that's where I work. And also it's a place where Muhammad Ali was born. And I'm sure that all of you know Muhammad Ali. I actually went to his funeral 3 years ago. We lost Muhammad Ali. And we have this beautiful museum that glorifies his life, but not just his professional life that was very successful, but which is even more important, his struggle for human rights and righteousness. And then University of Louisville School of Medicine is known for putting the first artificial heart in a human being, and also doing the first successful hand transplant. It's not a very big city. It has maybe 1.5 million people, but it's about 16th largest city in the United States. And as I mentioned, I was educated in Sarajevo in this beautiful maternity hospital that was just built. This was my chief of staff. He was an excellent surgeon, and I learned my laparoscopy from him. And he learned it from Kurt Sem, who is the father of laparoscopy from Germany. In 1992, the hospital was completely bombed by the Serbian aggression on Yugoslavia. And my apartment, these are the windows where I lived. This is on the main street in Sarajevo, in the center. And the tank hit this building here while this was already, at that point, I had moved to the United States. And my father, who was professor at School of Medicine, was killed during the war. And I found out about it 10 days later because there was no connection with Sarajevo. So now I'll talk to you about surgical techniques. And we have a conventional surgery that everybody knows. You have a patient, you take a knife and you make a huge incision and you operate. And then we have a minimally invasive surgery where we have a patient, we put them to sleep. We make what we call keyhole incisions, very small incisions, use specialized instruments, and we can operate and patients can recover much quicker. And then we have a micro-invasion surgical techniques where we use like a needle. We just put the needle in the vein, and through the needle, we can fit in the catheter through the different arteries, and we can do heart surgeries, certain heart surgeries, or we can do surgical procedures on other organs. And then eventually, we are developing non-invasive techniques, which means with patients that we don't even touch the patient. There is a instrument already when women have fibroids, and it's ultrasound instruments called HIFU, and we can put the patient inside, and then when we focus the ultrasound to it, patients don't feel anything, and we can destroy tumors inside the body. And the same thing is in the CyberKnife. So I will talk about these techniques. But the first known surgery that was ever described actually happened in Kentucky, very close where I live, about 100 miles south from Kentucky, Dr. Ephraim McDowell, and this is the year 1809, which is like 200 years ago, performed the first surgery on a patient that survived, and that was, I'm sure it was probably some other surgeries were done before, but never, it was never published. So this one's the first known surgery, and there is a museum in his house. The woman thought that she was pregnant. She was having, her abdomen was getting bigger and bigger. And after a year, she did not deliver. So she heard about this doctor that may do surgery that can help her. She got on the horse, 11 days, came to his house, and he was thinking, he was a religious man, so he thought if he does operate on Christmas night, that she will have a better chance of surviving. Anyway, she did survive. He removed a huge tumor from her, and it turned out to be ovarian tumor, and she did survive. So this is like first ever surgery, and there is a museum in this place where he was. So now, with the development of with the science and everything, we are able to do a minimally invasive surgery. We have so in conventional surgery, as I said, we make a big cut And this is, how you do the surgery. So this here film, I may be one of the few dozen people in the world that has copy of this film. This is a French surgeon doyen that worked in 19th century, beginning of the 20th century, 19 years in 1910 or so. And he is operating on a patient taking kidney out. And I will show you this film now. This film was found in a Portuguese archive of science. And you see, nobody's wearing masks. And it is very interesting technique. First of all, this is first recorded ever surgery. You can see the camera is always, nobody's blocking the camera view. You can see the operative field all the time. And another thing is, the entire surgery for kidney took only 4 minutes. I can speed it up, or do you want to see the whole film? He's an excellent surgeon. See, he took the kidney out, and now he clamped it. And now he's going to tie it. But nobody's wearing masks. Nobody's wearing gloves. And the patient still survived. It's very interesting because, like, we went in Nepal yesterday, and we operated, I performed 2 surgeries there. They make you change everything. They make you put the new shoes when you go in the operating room. In America, I walk in these shoes at home. I go to the operating room. We don't change anything. We don't put any shoe covers on. It's just the floors have to be cleaned, and that's anyway. So this is, I'm just going to show you here, the entire time of this video is 4 minutes. And look here, they closed it. So very interesting, right? So now the technology has advanced to the point where, with the help of technology, we can do surgery in much minimally invasive way. We have a patient, we have a surgeon, we have a technology interface that helps us do surgery. And the technology interface is these small tubes that we call trocars that we put inside the abdomen, and then we fill the abdomen, because everything in the abdomen is stuck together. We fill it with air, and then we create this space inside the belly, and then we put these special tubes that do not allow the air to escape out. And we have a specialized instruments that we put in. And since it's dark inside, we also put the scope that has a light, so we can see everything inside the abdominal cavity. And then this way we can operate. And the father of this was a French surgeon, Palmer, who was he was not the first to do this procedure. The first procedure was done by Jacobeus in the 19th century. but Palmer lived in 1950s, and he was one of the first one to start doing this successfully, and he also described entry point in the Palmer's technique. Another most famous father, what they call it, was Kurt Sem from Germany. I had the pleasure of meeting him several times, and he was an innovator, and he developed many instruments for laparoscopy. Among the most important was the machine that insufflates, puts the CO2 gas inside the belly, and also many other machines like the one that we can irrigate and clean, take out the blood out of the abdomen. And this is the way how we used to operate before. There was just like you would have to look through your eyepiece. Only the surgeon could see inside, and perhaps the assistant. And then with this gentleman here, his name is Cameron Najad, he said, why don't we put the video camera on the laparoscope and then everybody can see? And he has 3 brothers, and they're all surgeons in the United States, very famous. And I'm considered their 4th brother. And so when I came to United States at first time in 1987 in age, this was my mentor, very great surgeon who taught me everything, how to do correctly. And the instruments were quite primitive. We did a lot of, surgeries. The cameras were very big. And we also used to do laparoscopy sterilizations under local anesthesia. See, the patient is awake when we do these surgeries. And my mentor was a great teacher. You see, laparoscopy is very simple. You can actually just use air pump and put the air inside and use a flash, special scope with the light to see inside. And this is the equipment that we had at those days. And this is another famous guy who invented the bipolar. It's called Kleppinger bipolar, and he's the inventor of it. And another very famous laparoscopist, a good friend of mine, is Dr. Harry Rich from New York, who did the first laparoscopic hysterectomy. And before the war started in Croatia, 1990, I wanted to organize a meeting in Croatia, and I invited the founder of AAGL, American Association of Gynecological Laparoscopists, who came to Dubrovnik, Croatia, where we discussed to organize the meeting. However, next year the war started, and I became a refugee and moved to the United States. However, 10 years later, after working in the United States, I was able to organize the meeting in Dubrovnik in Croatia in 2002. And this is Kurt Sem, the father of laparoscopy, and this is Harry Rich. He is the most famous laparoscopist who did the first laparoscopic hysterectomy. Kurt Sem did the first supracervical hysterectomy, and that time I was nobody. But 20 years later, I did the largest laparoscopic hysterectomy in the world, which is 7.4 kg uterus that I took out laparoscopically. So to show you how laparoscopy works, you can, we go in the left upper quadrant. Oh, for some reason the films don't work. So anyway, we put the needle and we put the instruments inside, and we can see inside the belly what's going on. And in Louisville, we have a lot of obese patients because in America, there are a lot of obesity, unfortunately, and they are very difficult and challenging to do laparoscopy on. However, using this Palmer's technique, where we put the entry in the left upper quadrant instead of the umbilicus, we can insufflate all these patients. And this patient had 20 previous surgeries, open surgeries, and we did it laparoscopically for 21st time. And this had 10 previous surgeries, and we did it laparoscopically. So for you that are not doctors, this is the uterus, and this is something what we call frozen pelvis and endometriosis, a very, very difficult disease where we have to, everything is stuck inside, the patients have pain, and they also have infertility. And these are the most difficult surgeries, so we have to open up and show the ureters, which is the pipe that brings the urine in from the kidney to the bladder. And then we have to resect everything, so there are like the nerves and the ureter, and we need to be very careful how to do those. So basically, after cleaning up, the patients get much better. And I'm just going to, in the interest of time, I will show you, so this is from this year, from a situation where everything is stuck together. See, we get to the situation where we have cleaned everything and taken all the disease out. So that's, and very similar situation here. The patient also had endometriosis on her bladder. This is the uterus here, or her ovaries were stuck, and we call it kissing ovaries, and very difficult surgery, much more difficult than cancer. And we have to open up the pelvic side walls. Again, there is a way how to do that, and identify the ureter on both sides. I don't want to bother you with all of this, but you can see the bowel is stuck to the ovaries, to the uterus and everything, and it's tedious and difficult procedure. In order to help us, we suspend the ovaries and keep them out our way so we can operate easier, see better. And then we come down where the bowel is stuck to the uterus and to vagina, and we are able to open it up and clean this area here. We put some gauze inside. We can also do that. That helps us with the instrument. And this patient, in the end, she only has small incisions this big, and that's how we perform this procedure. In this situation, she also had so you can see here now we have cleaned everything. She also had a nodule on her bladder. So in the process, we had to cut the nodule from the bladder, and we entered into the bladder, and then we sutured and closed the bladder together. So here we have a hole inside the bladder. We can put inside the camera, we see that inside the bladder here. And now we take the suturing, and the most complicated stuff in laparoscopy is the suturing. So that's why we put emphasis on courses where we teach doctors how to suture laparoscopically. In order to avoid suturing, you can use a robot, which is a $3 million machine, but it's more important to learn how to do it than really spend money on very expensive machines. So this lady also had a nodule in the bowel that we are trying to take out. So here, this is the bowel, and we're using instrument to cut, scissors here to cut this nodule. But the nodule was going all the way to the wall of the bowel, and then we will use another instrument to put it through inside of the bowel, and then do what we call a segmental bowel resection. So we use the instrument that we put through the anus here, and we put it from inside to the anus through the bowel, and then we have a suture on the nodule that we pull inside this instrument, and when we close the instrument will cut and suture at the same time. Very sophisticated instrument. It's called circular stapler, and every surgeons, they use this. So you can put them, you'll see now how we're closing the nodule is inside the blades of this circular stapler. And once we close and fire the stapler, then we can remove piece of the bowel this way. So now we're taking it out and see we have removed the nodule of endometriosis that was going through the bowel wall. And then at the end we check, at the end we check everything and make sure that there is, and here very often after surgeries, I get these love letters for patients saying, thank you so much. I was able to get pregnant because you did surgery on me and so on. And as I mentioned, we did.
Presentation will demonstrate safe and efficient hysterectomy for the severely enlarged fibroid uterus. The MRI images here are of a 44-year-old female seeking minimally.
This lady had a 27 by 27 centimeter uterus, this big uterus that was 7.4 kgs. And look, these are all incisions that we did. So this is inside. When you get inside, you cannot see anything but just huge fibroids
5mm laparoscope.
all over the place. So I don't want to bother you with the whole film. I will just speed this up that we can safely detach everything, detach the uterus safely in order to remove it. So we're putting more ports in, we're using coagulation here. We see the ureter, which is the pipe that takes urine out. That's very safe to keep it far away from the area that we operate. And then once we now we can.
Now attention is turned back to the one remaining vascular pedicle.
And look here, we got in trouble now. You will see we are cutting the uterine artery, which is the main blood supply to the uterus. And we miscalculated. We thought that we coagulated it, but we got into the bleeding here. You will see how bad the bleeding can be, but we were able to manage it.
When in actuality, the lumen is very weak. High volume blood loss can occur in an instant. Hemostasis is achieved by placing pressure on the vessels with a suction irrigator and then desiccating, noting that the lumens can retract within the tissue. Gaining control of the lateral aspect of bleeding first is what is recommended. After securing all of the blood supply to the uterus, colpotomy.
So we were able to control that bleeding and we took the whole. So now we made a very small incision in her belly and we cut all the uterus out.
Extension of the umbilical trocar site and
it took us an hour and 40 minutes just to remove the uterus out. The whole surgery took 4 hours.
This process,
and you will see all this we were putting in this huge bucket. And this is the world record, the largest, because before there used to be 1 kg club where people would take a uterus, and 1 kg uterus is about this big, and they did 2 kg, and so on. So nobody has done 7 kg.
The patient chose to proceed with uncontained.
I did not try to do the record. I was just, we were doing it very safe. We were just trying to remove it laparoscopically, but it turned out to be a record. So see how this is my assistant. She's cutting it and
superior portion of the tissue specimen process is repeated. We find that Jacobs where heavy clamps work better than single sheets.
It's almost done, so I'll show you. And then we brought the scale.
7.4 kilograms. Total operative time was 4 hours, 12 minutes, and total estimated blood loss was 700 cc's. The vaginal cup was closed laparoscopically. And
then we closed it, sutured the vagina, and that was her belly at the end, only this much, for uterus this big.
This presentation.
So this shows that the laparoscopy is actually advancing in all areas of surgery. You can see here the appendectomies are in red. Surgeons, everybody is doing appendectomies. The yellow is what is this? Hysterectomy is the only one down. The gynecological surgeons, although gynecologists invented laparoscopy, we have done the least progress compared to other disciplines. You can see the cholecystectomies and appendectomy is yellow. Everybody does appendectomies laparoscopically. Cholecystectomy is also laparoscopically, and also bariatric surgeries. So, as I mentioned before, now there is this very expensive machine that costs $3 million, robot that does, here's how it works. It has a console, and the surgeon puts fingers into these here. They're like two loops, and these loops control the instruments that are placed on a patient. And then whatever surgeon does with his hands or her hands, the machine can replicate that on a patient. So it is a lot of clutter. You can't see the patient, but once you put all these instruments in place, then you can suture much more easily, intuitively than when you do it laparoscopically. And this is like suturing the mesh on the vagina for a surgery that we did this surgery in Nepal 2 days ago, just using conventional laparoscopic instruments. But a lot of people don't know how to suture laparoscopically very well, so do it robotically. So that is the principle. The robot is a very nice, excellent, but very expensive machine. And it's more important to really invest in education than just in robotics, but that's how it works. And the advantages, whatever you can do with your fingers, robot can replicate that. Also, if your hands are shaking, the robot can take the tremor out. So if you had too much coffee in the morning, your hands are shaking, robot basically can help you out. And now it's becoming very, very popular in the United States. This is in 2005, most of the surgeries were done open. And then this is in 2013, most of them, they got robotic and laparoscopic vaginal, and very few are getting to be open. So this is also in benign hysterectomy, the number of open surgeries is decreasing, and number of laparoscopic and robotic surgeries is increasing. So the most important thing is, because the advantage is generally, instead of cutting patients, it will take 10 days for the abdominal wall to heal. Patients go home without any incisions, and they heal much quicker, and they go back to work much quicker. And especially the oncology surgeons in the United States, they're using robot, and the open surgeries oncologically is falling down, and robot is increasing. And it's come to the point, the nice thing about the robot is the surgeon doesn't even have to be in the same room as a patient. Usually there are three parts of the robot. There is a surgeon console where the surgeon sits, like I show you, and then there is a patient, and where the robotic arms are placed. And then there is a third, which is like a brain of the robot. But the console doesn't have to be in the same room. It can be somewhere else. And this whole design concept was designed by US Army, because they wanted to, if the soldier is wounded on the field, they can put him in a special container somewhere, and the surgeon can be somewhere else, not in the same place, and operate on that person. So the first surgery, robotic surgery, that the patient was in France and the surgeon was in the United States, was performed in June 19, 2001. So 23 years ago. Imagine that, 22 years ago. The surgeon was in America, the patient was in France. There was a lag time of 1.155 milliseconds from the internet connection, which is very slow, very small, 155 milliseconds. The surgery lasted 55 minutes, and they took the gallbladder out from this. So, and it was organized by Jacques Marlot, who is actually another surgeon that I know. He is Marcos. He is in Strasbourg, France. And never mind, I'll skip that. I'm actually not a great fan of robot. When the robot first came, I started doing robotic surgery, but then I realized I don't need this expensive thing. I can just do everything myself. And then I wrote the paper where I compared the robotic versus non-robotic surgery, and they actually turned out to be best paper of that year, published in the JMAC journal, where we looked at 358 hospitals and on 36,000 patients. It showed that there was no advantage of robot compared to laparoscopy, except that robotic surgery was much more expensive, $2,000 per surgery. And then now robotics, they also make a single port robot surgery, which is instead of like having 4 or 5 small incisions, they just make one incision in the umbilicus, and that is better. And the future of robotic surgery should be something like this. And I'm not saying that, I'm saying that the future of surgery will be robotic surgery, but probably not in this shape and form that we have now. And this will be the future probably later on of surgery. And of course, the prices have to be coming down because there is only one company that holds all the patents and monopole and everything, and that's Intuitive Surgery in America. Now Chinese are developing a robot, and there is a second robot coming out this year that came actually last year, called Hugo by Medtronic. And that will basically, the competition will bring the prices down and also the quality. So it's important in order to do surgery to have the right environment and right, instrumentation to do these surgeries correctly. There's also single port surgery, which I'm not really a great fan of. I know it's done in Asia a lot. It's more difficult to do it, but I don't see much advantage compared to conventional laparoscopy. But there are a lot of other great things like ISGE that we can inject into the blood, and it shows us blood vessels, or it shows us tumors where they are. So when we operate, we can then, this is the same tissue, and this shows you where the tumors are that need to be removed. We can also do hysteroscopic surgery where we put scopes inside the uterus, and then we can also look and take the fibroids, polyps, and everything, and different things from the hysteroscope. And we can do also resectoscopes. If somebody has a mass like this inside the uterus, then we can remove that. And we can also treat the bleeding with different instruments. With here, this instrument has electric mesh. We put it inside the uterus for women that have problems with bleeding. And in like 3 minutes, we burn the inside of the uterine lining. And when that patient doesn't have to have hysterectomy, it is much more quicker. It can be done even in the office and much cheaper, and just gives us almost same effect. And then now we go into the micro-invasive surgery techniques. What I was telling you, you can put a catheter inside the vein or artery in the leg and come all the way to the uterine artery and embolize that artery so that the uterus will have no blood supply. And then if patients have bleeding or fibroids, those fibroids will die off. Also in other areas, like you can take a little pill and that pill will go all down to your bowel and will take picture of the entire bowel, and you get the diagnosis if you have any tumors or not. And those are all, now we're moving to the non-invasive surgery techniques where you have a surgeon and patients and they don't even touch each other. You know, you have this, what I said, the MRI focused ultrasound. You put the patient inside, it focuses the ultrasound from different beings direct onto the tumor so it can destroy the uterine fibroids. And there is this cyber knife for patients that have brain tumors that can basically do the same thing, that they just don't even touch they show the radiation, and the radiation is being focused beam right into the tumor and can destroy the tumor. So in order to do all these techniques that I've showed, surgeons need to be trained. So the most important thing is the training, and how do we kind of, help with that. There are other techniques also, such as, placing genes. We can do on a gene splicing and help doing new techniques on patients, and do also producing the organs. This is a friend of mine, actually, that I know in MIT. She developed this using, on a mice, she developed a human hair and from stem cells. So we can basically grow organs, and this is the future of medicine. As I said, for laparoscopy, the most important thing is training. Training can be very basic, like taking the instruments, grabbing instruments, moving them from one place to another. Then organized training where we can teach people how to do suturing, and we do this in the labs. There are also simulators that can simulate different surgical techniques. They cost, of course, more money, but you can have, like for robotic surgery, the simulator is almost as good as robot. And in order to be a robotic surgeon, you have to go to take these 10 different test levels, and they're so complicated, and they look very, very similar to the situation that you would find in regular surgery. But when I first came to the United States, I realized that the most important thing to being a good surgeon is to be to know anatomy very well. And the analogy that I use is, I can drive car very good, but I would be totally worthless here in Kuala Lumpur because I don't know the streets. So the same thing is, if the surgeon can be very good technically, but if you don't know anatomy, what is behind or where is close, where you're cutting, then you are very dangerous. So I decided in our institution, they had a fresh tissue lab, and I would take the students to the lab and basically steal the instruments from the laparoscopy suite or hospital and take it over there. And we would do surgeries on cadavers to look for retroperitoneal anatomy. And then we started doing the first courses in the world. By the AGL is this most advanced or important and the largest society of the laparoscopic surgeon. It's called American Association of Gynecological Laparoscopy. We started the courses first in the world to do the surgery on cadavers. And this is 10 years ago. We had people from 35. Now we have 45 countries that have come to Louisville to do these courses. And you can see we have usually 10, 15 cadavers, and we have 3 people per cadaver. and we teach them how to operate and do laparoscopic surgery. We also do it we had the robot, we can teach how to do robotic surgery on cadavers, the same thing. And then our lab was very primitive, basically in the basement, but we made a huge, the whole world knows about it. And then other people started emulating the same thing that we had. And in the University of South Florida, they built a $60 million center. This is probably the best one in United States. And I've been there, I've done at least 15 courses there where I teach. They invite me to teach on the cadavers. And this is one of the best in the world to do. And this is, see, they have very shiny, it's better than any hospital, basically, the lab with like 20, 30 stations. And then the second best is probably now the best one is IRCAD. And you probably heard of IRCAD. IRCAD is the French center that started in Strasbourg, France, and then has built the one in Taiwan. There is Taiwan IRCAD here. Has anybody been there in Taiwan? No. And then they have one in Brazil, and now they have one in Rwanda, and they're building the fifth one in the United States. And this is the famous French surgeon, a good friend of mine, Arnaud Vatier, that invites me to all these courses. And this is IRCAD. They have a pig lab, and we teach people how to operate on pigs. We also do hysteroscopy courses where we teach them how to on different stations and models. So this is the basically the organization in medicine in the United States. After you finish the residency, there are several, you can use maternal fetal medicine subspecialty takes 3 years, oncology takes 3 years, reproductive endocrinology 3 years, urogynecology 3 years, and minimally invasive gynecological surgeries 2 years. So we have the teaching, but the most important thing for doctors, you as a single doctor cannot do anything unless you organize, and you need societies like, and I know there is in Malaysian Society of Gynecological Laparoscopies, I know some people, but this is the largest world organization is AAGL. It's called American Association of Gynecological Laparoscopists. That at one point I was president of that organization in 2009. And they also run they oversee the fellowship program that we have at University of Louisville. My mentor, and I gave the name of the fellowship after my mentor and my other mentor, we started this fellowship. We've had 23 fellows that have completed this. And this short film, how much time do we have? Huh?
University of Louisville is located in
Can you
Louisville,
hear?
Kentucky, home to the Kentucky Derby, the first artificial heart transplant, and birthplace of Muhammad Ali. Louisville has also been ranked in the top 10 foodie cities in the nation. The fellowship program is one of the oldest programs in the nation. Initially started in 2001. The program has had 22 fellows since 2003. And the goal of our program is to train our fellows clinically and academically so that
Okay.
advanced laparoscopic but also be qualified for.
Okay, anyway, so this is a film about our fellowship, basically, and these are my two fellows.
Wide breadth and high volume of surgical experience.
First year fellow, here's our fourth year resident.
So we are, this is the,
Anytime.
we have research that we do also, but we have won many awards, my fellows. We have traveled many places.
Strong.
Okay. And this is the list of my fellows. I'm almost done. So this is the also International Society of Gynecological Laparoscopy, ISGE. We organize these different courses throughout the world, and we also organize the different training weeks where we can come to a certain place with our trainers, do live surgeries, give lectures, and people then can come for the training in minimally invasive gynecological surgery. So we also organize these different webinars. In 2021, when there was a COVID meeting, we organized a meeting that was 24 hours around the world in 3 different time zones about endometriosis. It started here in Asia, then moved to Europe, and then to America with all different speakers. And it was like 24 hours nonstop, like a marathon of live surgeries and presentations. Our next meeting is in Bali next week, and then in Beijing next year. So I invite you, if anybody who is interested coming. This is my website that you can, it's called gynlaparoscopy.com, that you can get a lot of these valuable films. And these are the books that I have published, 5 textbooks in gynecological laparoscopy. Thank you very much. Any questions? If you have any questions, I'll be happy to answer. Or anybody else.
Okay, thank you very much, Professor Dr. Rashad. And I think question will be after 2. We'll sit all of us and we'll receive all the questions. Professor Dr. Amia, you want to speak? You would.
Thank you, Dr.
Thank you, Associate Professor Dr. Persik. It's a wonderful presentation out of your expert. And the faculty members who are here, they have been pressurizing our CEO getting title professor. And our Dr. Persik has only the title associate professor.
Actually, it's an old thing. I am a full professor.
Thank you very much. I know. Now I'm just telling that you are such a wonderful person. And sometimes our faculty, without having such contribution, want to have title professor. That's what I meant. I knew that you are a professor, but I'm telling. How many of our academic faculty has done such wonderful contribution to the society and then claiming for professor? Can you please tell me in this all? So that you understand this. When people ask you to do that, please evaluate. I know properly. Thank you. So please be careful. Anyway, thank you, Professor Persik. Let me tell you, I lived in Zagreb. My international career started from Zagreb itself, then Yugoslavia. I landed at the age of 21, and before submitting my paper into the International Congress in Zagreb, they accepted and they invited me, dear Miss Amia. You are welcome. And I did tell them, I am not Miss Amia, I am Mr. Amia. Without correcting, they put me into the women hostel. And I was told that, look, you have to share the hostel room because it is international congress, 5,000 people. So I have to share. I said, okay, that's fine.
So you were in heaven.
I was in heaven. That's what I wanted to tell you this. No,
I'll tell you the reason for that is that in Yugoslavia, all names that have A at the end are female. That's why they could not figure it out. When they say A at the end, oh, this is female.
that's right. And then what happened? The middle of the night, and by the way, I flew from Moscow to Belgrade, and from Belgrade to Zagreb, I took the train. And by the time I landed in Belgrade, my luggage went to Copenhagen. So I had only the sling bag. In that sling bag, I had only the sandal and the paper, which I was going to present. So the hostel room where I stayed, so they said, you have to share the room in advance. I said, fine. But anyway, so middle of the night, I saw somebody was opening my door and I was only with the towel. So I got up, I said, what is happening? I saw a Hungarian lady was entering into my room. I said to myself, and I was on towel and so forth. And she comes in, she looked at me, are you Miss Amia? I said, oh my gosh. I said, no, I am Mr. Amia. And she sat down in front of there was a two bed, luckily, not the single bed. And she sat down, I sat down, she looked at me, I looked at her. And she went out. But anyway, she went out and got the reception and I changed my room. So that's the story of my Zagreb living. So I lived. It was a wonderful country. Unfortunately, when it broke down, and I'm in touch with my old friend in Bosnia. He runs a medical school. He has migrated to UK. And now, just 3 weeks back, I was in UK and we met up. We are trying to do something in Bosnia. We will talk more, Professor. Coming back to Louisville, my second deputy boss, she was from Louisville, Kentucky, when I was working for Otto University. So I have visited and I know very well where you are. Anyway, thank you very much. It's a wonderful experience which you have shared with us. And definitely we will set up as our mission vision. Dr. Sandeep is working and Dr. Song is working on this, and we will look forward. Thank you, Professor Percy. Appreciate sharing with your knowledge. And again, I would like to remind all of you, he has seen the work, he has seen the worst in his life, he has migrated, he has settled down, good professor, and having known, yet he takes the pain of traveling. And you do not know, I do travel, how much pain goes through, and yet he takes that pain. He operated some cases in Nepal. Yesterday he flew from Nepal. The worst airlines could be happen, though name is Himalayan Airlines, no business class, seats are tightly. I have traveled by that flight, Professor. Why he does that? Why he does that? That's what you should be. It's not the business. That's the human character. That's the medical doctor. That's as a human, you need to contribute in the society, the knowledge, the gain which you have received from the society. Please contribute without thinking how much money I'm getting. The moment that money, the material assets is in front, you cannot move forward in your life. And Professor has traveled, has seen the worst and has seen the best. he decides to contribute amongst the human being. So let's work together that we learn from him such a wonderful knowledge he is willing to share with us. Thank you, Professor. Appreciate. We hope we learn and we implement. Thank you and God bless.
Thank you, Professor Dr. Amia. Now we'll come to the break. So we have half an hour break, and our guests, respective guests, they will go to a hospital visit and come back after that 2 o'clock to here to complete the demonstration and also question and answer. Thank you very much. Okay. Okay.
Okay, ladies and gentlemen, we're going to continue with our group photo. So may I have all the VIPs to be in front, please? Yes.
Quickly, we sit down and share. One row and one row students can sit down, and another row can sit
Can I have the students up or no?
down. Yeah. It is. No. So one group. No, one row, 2 rows sit down, 1 row stand. Yeah, you understand this? So please bring it up, bring it up, so that you know. Yes. Bring it up, bring it up. That's it. Stand. Stand. So, okay. Okay.
Come, please. Dr. Amia, please welcome Dr. Risha. Please have a seat. Prof. Risha. Dr. Song, please come. Dr. Sari, please have a seat. Please have a seat. Probably please come in. All the students, all the participants, can you be on stage, please? Yes, all the participants, please be on stage.
Get the students down.
And students, you can sit down here. Sit down here.
All the boys can sit down, all the girls will sit down. Yes. Doesn't matter. Yes.
The girls can kneel down. Yeah, that's good. Yeah, good. Yeah, be practical.
So,
That's it.
It's going to go up.
Everybody sit down. No.
Okay.
And then show you that
Okay, please make sure you're packed. Okay, arrange your pack. On this side. Yes. Okay, you have to make it balanced. Okay. Okay. Ready? One. Smile.
Thumbs up. Thumbs up. 3, 1, 2, 3, come on. Camera now. Ready, 1, 2, 3. Need you smile, just please.
Okay. Smile. Smile.
Bye. 3, 2, 1. Again, 1, restart. Good. Yes, you go. Point to.
Dr. Reza and also Dr. Amia.
Yeah. Point to look at your face.
Hey, what do you think? Oh my. Okay. Okay. Thank you so much. Thank you so much. Okay. All the participants, and then we can have your short break for a while. Yeah. Thank you. And all the VIPs, we can have our break in a holding room. Please welcome.
Hari esok pasang yang siap lah. Tunggu datang rancang.
Gereja.
We can go to the meeting room. Can we invite Tati now?
Okay.
Meeting. We'll go to the meeting. We have arranged
Keep that back.
Take care of the back. Is it?
Please follow us.
Mr. Amit, announce any poll.
Okay, all the participants, we're going to have our refreshment in the room.
For half an hour, right?
In class.
Okay, now, so what time you have to here?
Doctor,
12.
12 now.
By 12 o'clock, you have to be in that, in
Hello,
the
Professor.
hall.
Professor.
So the tea break is on the opposite room. Please enjoy.
Ginseng.
No need. Hey. Can we just share from the Zoom here? Share slide? We can, right? Yes.
Dear participants, please take your seat. Welcome back to the session. I hope you have gained a lot of information from our eminent speaker. Is it? Okay, thank you very much for the response. Now, I would like to invite Professor Walid, our Deputy Dean for Clinical, to give his talk. Thank you, Prof. Walid. You're welcome here.
Thank you, Dr. Soya. And good afternoon, everyone. I'm very pleased to be with you here. Okay. Yeah, please come forward. Yeah, please come forward. You will see better if you come forward. Will it work from this? Thank you. So just by looking at you, I think the majority of you are undergrad medical students. Isn't it? Year 1 and year 2, or year 2. Okay. And online, do we have any surgeons? There are few doctors and surgeons with hospitals. Oh, that's very good. Because I really need to know for how further I need to go with my, lecture or talk today. What I have selected for you to contribute with this symposium about laparoscopic surgery is to talk about the use of laparoscopy in trauma. And basically, when we say laparoscopy, it has to be abdominal trauma. All right? So, okay. So this is the title of my talk today. I'm a general surgeon, and also I do peripheral vascular surgery. And I started my surgical training since the year 1984. From 1984 until 1988, I got my master training in surgery. I didn't feel that is enough, so I left my home country, which is Syria, to UK. And I worked in UK for 6 years, pursued higher level of surgical training, got my fellowship in surgery from the Royal College of Surgeons of Edinburgh. And as you all know, that laparoscopic surgery started to become more popular in 1989. So I was there and I started seeing all the pitfalls, the difficulties, and that we surgeons faced in the laparoscopic surgery. And with that, getting popular and the standard way of doing some general surgical procedure, everybody had to learn. In that time, I was in my 30s, but at the same time, there were people or surgeons who were at their age of 60s learning, we were learning together. And gradually, we gained this experience, and then from there, we applied on our patients. So one of the applications of laparoscopic surgery is to utilize laparoscopy in the assessment and management of trauma victims, all right? However, I think Dr. Ersad has given some good introduction how laparoscopy evolved over time. And this is some history, very brief history. I'm not going to go into details as he did, but let me tell you that laparoscopy is not something new. It started from 1901 by Kelling, who did the first laparoscopy on dogs in the animal lab. And then Jacobius was the first one in 1910, did laparoscopy on humans. But in that time, of course, the video camera was not invented yet. So the surgeons have to insert a straight metal tube with lenses inside, that is called scope, and to look with direct vision and move as the scope moves, and to look into different areas of the abdomen. Okay, so it was really tiring and exhausting work. This is why it was only done to look inside the abdomen, to explore, but not to do any surgical procedures. However, gynecologists were the first to start some therapeutic procedures in order to clip the fallopian tubes as kind of contraception, because this is very quick thing that we only put two metal clips, to close the fallopian tubes. And surgeons used to use the laparoscopy in that old-fashioned way, without a video camera and transmission. Used to do it to to assess tumors and to take biopsy from inside the abdomen. So this is how things developed over time. Now, the first record about the use of laparoscopy in trauma was in 1976 by Gazniga. And then the laparoscopy as a field of practice in surgery became popular in 1989 when first laparoscopic cholecystectomy was performed, okay, in France. After that, we started doing a lot of things laparoscopically. So we moved from cholecystectomy, means removal of the gallbladder because of the stones of gallbladder, to removal of appendix, appendicectomy. Then we started repairing inguinal hernias. Then we went up to repair diaphragmatic hernias and to do, anti-reflux procedure for the people who have GERD, all right? And then moved to removal of spleen, splenectomy. Then we started doing some more complex bowel surgery on the small bowel as regards the morbid obesity procedures, and on the large bowel, mainly for benign conditions like diverticular disease or for colorectal cancers also. Later on, pioneer surgeons started to operate on the liver and do hepatectomies. Nowadays, nearly every surgical procedure inside the abdomen can be done laparoscopically. And even cardiac surgeons now, they can do coronary bypass on the same principles, but using, of course, different instruments to do coronary bypasses. But of course, it's very difficult. It is time consuming. Recently or lately, they started doing it as a robotic assisted for the coronary culture. The use of laparoscopy in trauma, if we look into that, this is not very new. Again, it started, do you have a laser pointer here? Yeah, it started back in 1925. And this is the first record of applying laparoscopy to the trauma victims. In that time, the term that was used, cilioscopy instead of laparoscopy. Cilioscopy means the peritoneal cavity observation or inspection by a scope. So this is how things moved with regards to laparoscopy in trauma. Now, is trauma a disease? It is a neglected disease, not a disease. It's not a true disease, but the size of the problem is more than what you may think. If we take the statistics related to Malaysia itself, trauma itself kills about 24 out of 100,000 citizens. And sadly, those citizens who are usually get to be a victim of trauma are the young people, because young people, they get on the motorbikes, they are active, they are working, working in the society, working people in the society, so they are exposed more to accidents and traumatic problems. So we lose a lot of our youngsters because of the trauma. And this trauma could be multiple trauma in most of the time. And as a multiple trauma, abdomen is involved, all right? Usually it is involved in about 15%. Chest and head will also be involved with in other cases. Okay, so in Malaysia, it is the records is one of the worst in Southeast Asia, because racing on motorbikes, racing in cars, it's a culture, unfortunately, and this leads sometimes to really dangerous accidents, and those patients may not reach to the hospital alive. So, if we try to classify and we focus on the abdominal trauma. Generally, we can classify the trauma of the abdomen as a blunt or penetrating or a blast injuries. So what do we mean, or what's the difference between? The blunt means that there is no penetrating objects, no laceration. The abdominal wall is still intact, all right? While the penetrating injury, like the picture in the middle here, okay, as you see, it could be with a stab wound or due to a stab wound, an injury with knife due to assault, of course, or it could be a gunshot. So both of them are called penetrating injuries. And of course, with this kind of injuries, there will be something inside injured, either punctured or lacerated, cut open. So anything can happen. You know, behind this knife, we have small bowel, large bowel, and the tip of the knife may even reach to the retroperitoneal structures. Okay? Yeah. So this one, as you see here, although there are marks, but there is no actual cut, actual opening into the abdominal wall. By the way, any one of you knows what is this medical sign, or what is this sign here, obvious in this picture? Why do you think the patient is bruised here and there? From seat belt. So this is called seat belt sign. When we see a patient presenting with this sign, we know that there is a serious injury inside. So we must take this patient seriously and look for any injured structures inside. Okay, could be solid organs, could be hollow organs. And when we say solid organs, we mean the liver, spleen, pancreas, and kidneys, of course. The rest are the bowels, which are whole organs. Now, the picture on the right side of the screen, you see the bowel is bruised but not perforated. Sometimes it bursts also. This is the kind of blast injuries. If you have an explosion, because of the sudden changes of the pressure that give an impact on the abdomen, although nothing is penetrating, but bowels can be badly bruised and becomes ischemic, and later on it will perforate after a few days. So these are the three main categories of the abdominal injuries that we see in practice. Now, the abdomen, when we come to assess abdominal injuries, we know that part of the abdomen is hidden under the chest, okay? Because the abdomen has an upper or superior boundary, everything is below the diaphragm on each side, down to the pelvic floor. This is abdominal cavity. So when we come to assess and examine the abdomen, we actually, with our clinical examination, we can only examine these parts and palpate and auscultate, but these parts, which are hidden behind the chest, are difficult areas to assess. And similarly, the deeper part of the abdomen in the pelvis, okay, in the pelvic cavity, again, one of the areas which are difficult to assess. In addition to that, the structures which are behind the peritoneum, in the retroperitoneal space, again, they pose difficulty when it comes to assessment. So, how trauma generally is assessed and managed? Wherever you go across the world, we follow what we call ATLS system. And every patient in the trauma assessment and management by a team like this, is called trauma team, has to go through these 9 steps of management of trauma. So of these 9 steps, these 2 may be before the hospital, or we call them pre-hospital. And then once the patient steps into the red zone of the accident and emergency department, he will be assessed according to primary survey, ABCD, with immediate resuscitation measures. The aim here, because the role of laparoscopy will come here in the end, okay? But we cannot escape these steps. So laparoscopy does not mean that we will neglect or escape these steps. This primary survey aimed to discover medical conditions that poses immediate threat to life. Because we have to give priority to these in our assessment. The patient will not die instantly if his small bowel or colon was perforated. If you overlook this problem, your patient may die after 3 or 4 days. Okay? But if you overlook a tension pneumothorax or a pericardiac collection of blood or cardiac tamponade, or you miss airway problem, then your patient may die in few minutes. This is why the system of dealing with patients who are victims of trauma has to go through the more threat to life first, then we give our final definitive management. So I do not want to trouble you a lot with this because I shall repeat this again to you in more details when you come with us to Kotoba. How were the abdominal trauma victims assessed over the time? So we have something under secondary survey, which comes after the primary survey. Here we take more detailed history. We also do more detailed physical examination from head to toe of the patient. Okay, and of course, when we suspect that this patient has an injury to an internal structure in his abdomen, we have to do something to try to find out, is it bleeding, is it perforation, or is it just the abdominal wall and the patient is contracting his abdominal wall muscles and making it difficult for us to assess. So we really need those adjuncts. And one of those adjuncts is the diagnostic peritoneal lavage. What do we mean by this? We mean that we insert a needle, we infuse normal saline, and then we let it to stay in the abdominal cavity for a period of time, and then we drain it out. If it comes red, like what is happening here, this means that there is some blood inside, okay? So that's very simple. Now this one is losing popularity, it's losing its application because nowadays we go for the more, sensitive test, which is focused assessment with sonography for trauma. In brief, we call it FAST. And with the popularity of ultrasound and availability of the ultrasound machines in every emergency department, we no longer need to do this to look for blood inside the abdomen. So we go for this test, and then we check if there is any blood around the liver, it's likely that the liver is injured. If there is a blood around the spleen may be injured. If there is a blood in the pelvis, it could be pelvic organ or could be any part in the abdomen that needs to go down. Then, if we want to assess further, we do the CT scan, okay, which gives us a cross-sectional study so we can scan and look in every centimeter of the abdomen from the diaphragm down to the pelvis, okay? And in this way, we make a final diagnosis of the injured organ, and then we make our plan for definitive management. Now, we don't send anyone to CT scan if he is unstable, because in the medical literature, many patients died in the X-ray department on the CT scan machine. So the patient must be stabilized before we do send them for CT scan. So let me just skip those because this is to tell you what are the advantages, disadvantages, if we let alone the TPL, diagnostic peritoneal lavage, look into the FAST and CT scan. FAST, of course, is related to the skill of the person who does it. The CT, we can read according to our knowledge of the anatomy. The surgeon can read like the radiologist, and they can rotate the image, okay, and look into different, to the same organ from different angles, right? It is quickly performed. This one takes a bit longer time to perform. Both of them are non-invasive. And of course, for the ultrasound, there is no need to transport. We do it on the spot in the same room in the red zone, while here we have to transport the patient to the radiology department where we have our CT scan machine. Okay, so the disadvantages, of course, again, operator dependent. Here it costs a little bit more. The CT scan requires injection of contrast. The patient may be having kidney problem, kidney injury problem, or the patient may be allergic to these contrast materials. So we have to be careful when we imply that. Okay. The weakness of the ultrasound, it does not assess the retroperitoneal structures. We have a very important structures, retroperitoneally, major vessels we have, the aorta and vena cava. We have the renal vessels, of course, the kidneys themselves. We have parts of the colon, descending and ascending retroperitoneal, and most important also the pancreas. Unfortunately, the ultrasound is weak when it comes to assessment of these structures, while CT scan has better ability to assess those areas. Okay, so what are the indications? Any patients with abdominal trauma, okay, with hemodynamic abnormality, means that due to hemorrhage, due to reduced intravascular volume, should go for FAST. And of course, if the patient has penetrating injury, we need to know whether this, penetrating injury has injured any structures along the path of the injuring object. Same thing for a CT scan. So, when it comes to laparoscopy, now, here we do not look at the ultrasound images or CT scan images black and white. We look at the patient organs with our camera so we can see exactly what is happening inside the abdomen. And that's the beauty of the laparoscopy, okay? And this is why it is a little bit more accurate than those structures. I'll give you an example. Right. Here in this photo on the left upper of the screen, there is a pool of blood. The ultrasound will tell me there is a fluid, but with the laparoscope, I can see that this is blood. I can see that I can go with my camera up until I see the diaphragmatic surface of the liver. I can lift up the liver with another device and look under the liver and assess the injury. How bad is the liver injury? This is another condition. You see this little hole here, okay? It is impossible to see this with ultrasound. It is again impossible to see this hole with CT scan. So this kind of patients, we rely on clinical assessment. And sometimes at the start or at the immediate period after the injury, the patient abdomen examination may look normal or may feel normal to you. But after several hours, when the leakage of intestinal fluids and peritonitis starts to play up, then the abdomen becomes, the peritoneum becomes irritated and the abdomen starts to be rigid. But with the laparoscope, we can see, and not now see only, we can even stitch. So we close it. Previously, if we suspect a bowel perforation, we need to do laparotomy and do a big incision. And when we do a bigger incision, of course, the patient needs to stay longer in hospital because he will go into paralytic areas after that. He will not breathe comfortably because of the pain from the wound, so he gets some respiratory problems. And he's exposed to all problems of the wound infection, wound dehiscence, incisional hernias later on. While if we do that with laparoscopic approach, we just go through small, small cuts in the center of the abdomen to put the camera and another two just to insert our instruments to handle the bowel and visualize everything. Then the chances of this long wound problem is all removed, okay, and the risk. So this is another case of gunshot injury. Gunshot injuries are not very common in Malaysia, but if you take cities like New York, it's very common. If you go to some countries in the Middle East, it's very common, okay? So these injuries, again, can be assessed accurately with the laparoscope, and not only assessed, it can be treated, all right? Yeah. So, what is the aim of laparoscopy? Number one is avoidance of negative laparotomy. This is something I did not mention earlier. Sometimes we think that there is an injured structure inside that needs to have laparotomy. And then on exploration, the exploration is negative. So the bleeding from the spleen has stopped, or the bleeding from there is no need to do any further action. And the bleeding from the liver has stopped. There is nothing required laparotomy, okay? So these are the things that can be avoided when we include the laparoscopy in our management of stroke. Then, of course, it will increase our diagnostic accuracy, and it allows us to repair some of the existing injuries when we see them. So the benefits, if we try to summarize it, it will reduce the operating time, because logically speaking, when you do longer incision, you need a longer time than doing 1 centimeter incision. And again, the closure time for a laparotomy wound takes longer time than closing just 1 or 2 keyhole in the abdominal wall. It will reduce the stay in the intensive care unit post-operatively, because those patients without large wound, large incision, they will do better post-operatively than those with laparoscopy. And in total, or in the end, the hospital stay period will be reduced also. And the morbidities from respiratory system or respiratory complications that commonly occurs after, the major surgery is less, and it will decrease the wound complications, so the patient in the end can return quicker to his work, and finally it reduces the cost on the national health services. So points to consider: who is the candidate for laparoscopy? Can we take everyone? No. The patient must be stable, and stable hemodynamic. As you know, bleeding is one of the primary problems in any trauma victim. And bleeding leads to variable degree of hemorrhagic shock and reduced intravascular volume. I'm sure you have been taught under the physiology and under the clinical exposure, maybe, that hemorrhagic shock has 4 grades, or is classified into 4 classes. So Patients who are in class 1 and class 2, not hypotensive, but they do have disturbed other parameters like tachycardia, tachypnea, widened pulse pressure, these kind of findings, okay? But still considered normotensive and stable hemodynamically. Those patients are good candidates to go for laparoscopy. Then, of course, in blunt injury, if we compare laparoscopy to TPL, easily we can say that laparoscopy is more sensitive. When it comes to assessment of particular structures such as the diaphragm, because with crushing injuries, with decelerating injuries, you understand the term deceleration, the opposite of acceleration. When a car hits another car or hits a post, the speed of the car suddenly is reduced within a short period of time. So the passengers inside the car, they are moving in the same speed of the car. And suddenly this, if the driver is driving by 80 or 90 kilometers per hour, it means that his body is achieving this speed and within a second it's going to zero. So this is decelerating injury. So it gives a great jerky impact on the body and in particular the abdomen. So that's sometimes leads to injury of the liver, injury of the spleen, and even the diaphragm when the area of the lower part of the chest is compressed, against the steering wheel. And this is how we get diaphragmatic rupture. Another mechanism of diaphragmatic ruptures, we get it by stab wound in the lower part of the chest or gunshot. So there is a good benefit if we use it for gunshot. And again, whether the injury is blunt or penetrating, the patient must be hemodynamically stable. If the patient is in severe bleeding, in hemorrhagic shock class 3 or 4, it is better and safer to go for laparotomy quickly and manage the injured structures by damage control procedure. So one of the things to remember that not everybody is trained to provide this kind of procedures. Do not provide laparoscopy in trauma if you are not trained originally as laparoscopic surgeons. And sadly, sometimes the trained people and experts are not available at the out of the working hours, So it's very difficult. The intermediate staff, the MOs who are in surgery, the master, students, master student doctors, they may have been exposed to laparoscopic procedures, but they don't have the adequate experience, and that is one of the obstacles of making it available everywhere. Another problem is the availability of instruments. Sometimes it is available during the day and working hours, but not available during the after working hours. So this is one of the negative things about laparoscopy and needs to be remembered. Again, blunt trauma with hypotension. We do not want to waste time. We go for a stage, so for class 3 and 4, we go for laparoscopy. If the patient is hypotensive, severely hypotensive, after penetrating injury, we suspect a major vascular injury. And we know that major vascular injury cannot be repaired by our laparoscopic instruments. Just before coming to your country, I had a 14-year-old girl who was injured by a flying shrapnel, which is about 1 centimeter. And this shrapnel went through her loin area, and she arrived to the hospital shocked completely, nearly exsanguinated. So on laparotomy, we found that her abdominal aorta was lacerated, okay? And luckily, she survived after controlling the bleeding, resuscitating her with blood and fluids, of course, and clamping the aorta, repairing the last area of laceration. And she did well and left the hospital on the 6th day. Okay, so sometimes we face these situations where laparoscopy is inappropriate. If we make the wrong decision and we insist on applying it to every patient, we actually kill more patients. Okay. Yeah. Now, gunshots with that traverse the peritoneal cavity, but with a hemorrhagic shock, of course, evisceration. If the abdominal wall is already cut open and bowels are out, there's no point, and it is illogic to go for laparoscopy of those patients. Okay. Then, of course, if there is a frank peritonitis, the patient comes late. Not all patients with stabs come straight away to the hospital. Sometimes people may, either see a doctor or for some, legal problems, they escape, the attendance to the hospital facilities. And then when they get worse, they come to us with a stage of peritonitis already. So those people are not candidates. We cannot inflate air inside the abdomen, and there is a collection of pus. So we spread it all over. We might kill the patient from, inducing severe bacteremia and later on septicemia and septic shock. So it's inappropriate use. There is already a free air or retroperitoneal air. We know that retroperitoneal structures are difficult to deal with, so we may opt for laparotomy rather than laparoscopy. Similarly, rupture of diaphragm, if it is a small rupture, it can be dealt with, especially if the patient is not in severe hemorrhage. We can deal with it and we can repair it. Now, what are the complications? Is it absolutely safe? No, like any procedure, it has its own complications, and we either have to minimize or to avoid. So one of these is tension pneumothorax. When we inflate inside the abdomen, normally we inflate the abdomen with CO2 gas slowly. In order, why do we need to inflate? Because we want the air to spread the bowels apart from each other, to give us a space to maneuver, and but if the patient has a rupture in the diaphragm, air will go to the pleural cavity. So we give the patient now iatrogenic tension pneumothorax. So once we see the diaphragm is injured, we immediately lower down our inflation pressure. And we have to be careful. Otherwise, we give the patient tension pneumothorax. Another problem, sometimes the patient does not have a bowel injury, he has other injuries. With our insertion of trocars, we may, puncture, because the trocars are like daggers, it has a very sharp pyramidal end, okay? So inserting those trocars inside the abdomen with the heat and the speed of working fast, you are, excited and very keen to save the patient life, you may do a damage by inserting those instruments. And that comes with limited experience when it is applied by inexperienced people. And of course, there are ways to avoid this, I will mention. Missed injuries. Sometimes you do the laparoscopy, but you check the bowels and you overlook a little hole or you overlook an injured area. All right? Again, increasing the hazards of elevation of PCO2. If the patient has respiratory problem, when we inflate the abdomen with CO2, okay, this CO2 will be absorbed from the peritoneal cavity, and it will go to the blood, okay? So we increase the level of CO2 in the blood. If the patient is already having respiratory problem, then we make it worse. So a good oxygenation must be assured during all the procedures of laparoscopy. If there is an injury to large vein, like renal vein, inferior vena cava, and with inflation of gas, sometimes we induce gas embolism, and we will notice that the patient blood pressure suddenly drops, okay, because of this. Then, if the patient has head injury, and already with increased intracranial pressure, by inflating the abdomen, this will lead to increase in the intracranial pressure flow. Let me show you this here. Now, so I will go to the contraindications of laparoscopy. Shock, class 3 and 4, obvious peritonitis, penetrating injuries plus shock, okay, suspecting major vascular injury, previous multiple incisions. A single incision from previous operation is not a contraindication. But if the patient has several laparotomies, in emergency setup, it is contraindication. In elective setup, you heard Prof. Rashad saying that he has done his hysterectomy on a patient who had 6 previous incisions. It's elective. You can spare some time to divide the intra-abdominal adhesions. But in emergency situation, you don't have that time, okay? Evisceration and lack of experience or equipment of staff or staff in general. Okay, the disadvantages, as I said, incomplete assessment sometimes, difficult to assess specific anatomical areas like the posterior parts of the liver, it's impossible to see, or the area which is around the or close to the inferior vena cava of the liver, and some areas, the lowest posterior part of the diaphragm. The dome of the diaphragm is very easy to see, but the lateral sides and posterior inferior sides are different. And of course, it needs the availability of trained staff. How it is performed. As you see, our laparoscopic set looks like this. So we have here the screen that we can see what is inside the abdomen. This is our video processor connected with cable to the camera. This is our insufflating machine. This is our irrigation, and maybe this one is just a diathermy to use electrocoagulation to arrest any bleeding. I don't think, since you have not done surgery, the majority of you, I don't think I need to go through the instruments, but basically we need trocars, okay? The biggest one is 11 millimeter to insert the camera. And nowadays we have cameras which are 5 millimeters, so we can go for a smaller incision, but the 5 millimeter camera is not suitable for the emergency procedures because it's a delicate one. Then we need 2 ports to give us access. So one is for inserting the camera, another 2 ports in order to work with 2 hands, okay, to manipulate the balance. And then we need another scope that, in addition to the 0 scope, we need a 30-degree scope. The 30-degree scope, the tip of the scope is chipped into 30 degrees. So it can show the pelvic areas and under the diaphragm, under the liver, better than the 0 scope, which can give you only a front view, okay? So that gives a wider angle of vision. Irrigation and suction, stitching and tying facilities, and methylene blue. Sometimes if we are in doubt or about a perforation, we can instill methylene blue and check it whether it leaks out or not, especially for the bladder injuries. So we can infuse the methylene blue through the urinary catheter, and then we look inside with our camera, we get close to, we fill up the bladder. If we see the blue dye leaking out, it means that there is a rupture. And we can do the same thing for the stomach also. So this is how the operative field would look like. And this is the 3 incisions, 3 ports, either supraumbilical or below umbilical. This is our main port that we insert. We make the first incision through. We can either use this trocar, which is called Hassan-Baker trocar, and or use the one which has a blade, and we can insert the scope, and while we inserting, we actually see the abdominal wall layer by layer. Okay. This is the technique I think I've just explained. Okay. No. Now, sometimes during the procedure, we have to alter the patient position. So when we need to inspect the upper part of the abdomen, we need to get the patient head up. And that is called reverse Trendelenburg position. When we need to inspect the pelvic areas, we put the patient head down, so the bowels will go up and the pelvis becomes empty, except the pelvic organs, which are the bladder, uterus, and the rectum. Okay, so usually we need to do this manipulation. We also manipulate the bowels by 2 instruments by moving it from one side to another. We sometimes need to tilt the patient right and left, okay, in order to let the bowel by gravity go away and from hiding in view. Then if we see, once we are in the peritoneum, with trauma, we mainly look for the presence of blood and we try to assess the blood. So here it's classified into 4 degrees. The first one is there is no hemorrhage at all. Second one, minimal hemorrhage. Third one, moderate. And fourth one is a severe hemoperitoneum, where we have to go straight away to laparoscopy. What can we do? What therapeutic actions we can do? If there is a laceration on the liver, we can use electrical diathermy to arrest the bleeding. If this did not work, we can pack. We just put a piece of gauze and we give a pressure over that wound in the liver to try to arrest. If this doesn't work, we now have some materials that we can spray there, like the glue. Okay, it's called fibrin glue. So it will arrest the bleeding. Again, we have another, things that we call it the flow cells or hemopatch or Surgicel. These are made like small pieces of gauze, contain the coagulation factors that will get activated once they are in contact with the blood. And finally, they form a blood clot, and this blood clot will seal the opening of the capillaries in the injured area. So there are many ways, many things to offer to the patient in order to avoid doing laparoscopy. People in the literature talk about autotransfusion, means you take out the blood and retransfuse it again to the patient. It doesn't work well in abdominal cases, but it works well for bleeding inside the thorax. Okay. Small stab injuries in the stomach intestine can be repaired. We can you know. So with our scope, we don't only just have a graspers and camera and suction. We do have stitching instruments. We push needles inside. We can stitch the tissues as we do with our open surgery. For the diaphragm, we can either suture it if the laceration is small, or we need to put sometimes the edges cannot be re-approximated to each other easily, and we just put an artificial mesh, artificial piece of tissue, which is made of trolling, okay, polypropylene or mercery, and we just stitch it around the gap. So we prevent the herniation of the bowel contents into the thorax. So these are examples, okay. This is a hole in the diaphragm. Here is the pericardium. This is the lung here, okay. So we have to close this hole by stitching. This is another condition where the spleen is injured here, okay. And we treat this patient, when we see this, we treat him as conservative, to give him blood, fluids, and that's what we call it non-operative management, NOM. But sometimes this works, and sometimes the patient continues to bleed and continues to require blood transfusion. Then we have to put an end to that. So we go with our laparoscope and we do the either splenectomy or partial splenectomy, or one of those electrocoagulation, which I told you about, or arresting with Surgicel. This is a patient who had a stab wound injury, okay, and you see there are some fibrin here. Actually, this slide was off. This is better. It's not one. I don't think the pictures. No, yes, maybe slightly. Yeah, it's better. Thank you. So as you see here, the mucosa has everted out. There are some fibrin. This has been going on definitely more than 24 hours. So it was initially missed injury, but when the camera was put on with the laparoscope, now we can see where is the problem. And then we can pull this up and use a device to seal and close, okay? These are the endostaplers, all right? We can close this kind of injury laparoscopically, there is no need. So, any questions until now? Question later. Okay. Finally, let's look what the literature says about this. Is it in support of what I am saying or not? So this is a little bit of the literature review about the same topic. This is by Gazzaniga in 1976, who did 39 laparoscopies for abdominal trauma. 24 patients were blunt, 15 were penetrating trauma. And he found in blunt trauma, 42% were negative on laparoscopy, and laparotomy was avoided. So there was no need to do a laparotomy on them by just doing laparoscopy. In the patient with penetrating, in 39%, he was able to avoid laparoscopy. This is one of the difficult situations. When you receive a patient with stab wound, you aim to look if this wound has penetrated the peritoneum or not. But sometimes the length of the wound does not allow you to do that. You need to extend it. You put retractors. If the patient is obese, you really need to extend it a lot. And then you find a little hole of the peritoneum. You open the abdomen. I'm talking about if we have to act without laparoscopy. Then you find that there is nothing injured. Although the knife went in, but it just touched the bowels, but it did not penetrate. So this is a very common scenario for a negative laparoscopy. If we stick our camera in and we look and examine the bowels, then we can avoid this patient of having a large laparotomy incision. Okay, so this is what has been confirmed by that previous study. Now, Percy used to do laparoscopy in the emergency room under local anesthesia, do small incision and insert the camera and do a quick look and examination of the bowel. In that time, in 1980, if there is a bleeding, he did that in order to replace, or to avoid laparotomy. If there is a bleeding, he would do laparotomy if it is a large amount, because there is, grade 1, 2, and 3, as we mentioned before. So again, he did this on 150 patients with blunt trauma, and 84 of them, 56%, had negative diagnostic laparotomy. There was no blood. And 25 had positive but minor hemoperitonea, who did not require, although they have amount of blood inside, but they did not require surgery. When we say blood, sometimes, most of the time, the bleeding from the spleen or the liver, by the time we intervene, we found it that it has stopped. So we just aspirate this blood, we place a drain, and that's it, a small tube of drain. And in 28 patients, 19 of them had positive, but they needed laparotomy because extensive injuries were found. And one patient, unfortunately, had negative diagnostic laparoscopy, means that there was a missed injury. And there was an injury to the sigmoid, which was perforated, but unfortunately was not seen. After a few days, maybe this patient kept deteriorating, not doing well, and finally they decided to do laparoscopy. So the literature, I started from the old to the most recent. This is by Alfred Kucheri, who is one of the pioneers in surgery, and especially in the field of surgery. He is based in Nine Wells Hospital in Dundee, in north east of Scotland. He did a randomized study. He took 55 patients with blunt trauma, randomized them into two groups. One will go for diagnostic peritoneal lavage, and group 2 will go for laparoscopy. And both tests had 100% sensitivity, detecting intra-abdominal, but BPL had 83% specificity comparing with laparoscopy. So the study is very small. I will skip that, only 8 patients. This is a study that I think in 2021, this is one of the recent studies, which is a single surgeon experience, 19 patients, blunt injuries, 63% had blunt, and 36 had penetrating injuries underwent diagnostic laparoscopy. And he found that diagnostic and therapeutic laparoscopy reduced the hospital stay, comparing it with laparotomy from 13 days to 5 days. And in conclusion, laparoscopy is feasible and safe and in stable, hemodynamically stable patients. This is another study from the literature review published in 2021. This is a meta-analysis, 19 studies involving 1,520 patients, all of them hemodynamically stable. Confidence interval is a shorter hospital stay in laparoscopy versus laparotomy. And he concluded also that missed injuries is 0.3%. We're talking about 3 in 1,000. And comparing it with laparoscopy and even with non-operative approach, when we choose to treat conservatively, so we miss 4 in 1,000. And laparoscopy in stable patients is safe and feasible. Laparoscopy versus laparotomy. This is another study also in 2022. Meta-analysis study, 23 studies, 5,000. This one I think is from China. 5,517 patients. There was no significant difference in incidence of missed intra-abdominal injuries, mortality, and mortality also between laparoscopy and laparotomy. The post-op morbidity is less in intra-abdominal, regarding intra-abdominal abscesses, regarding thromboembolism, the DVT or PE mainly, and post-operative ileus were similar. Laparoscopy group had less wound site infection, nearly half, 2.5% versus 4.8%. Pneumonia also is 1/4 comparing the laparoscopy to the open. And of course, it was a shorter procedure time. So again, laparoscopy is, sorry about this, a practical alternative to laparotomy. I think that's all. I have attached to this PowerPoint, which I will make available to all of you. There are some videos which are interesting, will take you through different situations where the laparoscopy has been applied and therapeutic measures, where include like stitching parallels, dealing with bleeding inside the abdomen. And these are my references. Okay. And thank you very much.
Thank you, Professor Walid, for your informative speech on the role of laparoscopy in abdominal trauma. Can you please give him a big clap? Thank you once again, Prof. Okay. A small announcement. Now we will discuss for the lunch break. At 2 p.m. we will meet again. For your kind information, we have arranged a lunch at the ground floor cafeteria. So our committee members will guide you to take to the place. Please be here by 2 p.m. The guests will be arrived by 2 p.m. Okay. Thank you. For the online participants, just the information for you, we will share all the PowerPoint presentation which was delivered by the speakers, and all the videos we will be shared you to your email. Thank you very much. Please be here by 2 p.m. both the online as well as the face-to-face participants. Okay. Thank you.
I do the target. I cannot then I don't. Training we have it's very difficult. We have a long life. Hands out a long Those one. Yeah. Well, yeah, I 5,000 for one.
There is one hour delegate is there. You Sir?
Good afternoon to all. Welcome back to the session. Now we will start the demonstration session using the laparoscopy equipment set. For this session, we would like to invite Mr. Wodong Bjorn, Deputy General Manager of Jinmyon Medical Technology. Can we give him a big applause? Mr. Dong Jin Yu, Overseas Sales Director of Shuhan Jingdong Medical Technology. Mr. William White Dong Zhu, CEO of Multi Companies, Koi Capital Partners, British Columbia, Canada. Mr. Zi Fuzhu, Chairman of Fusion Secure Medical Technology. We are welcoming you for the demonstration session. Thank you.
Your any kind money paper
Okay,
Or you have a, yeah, you have kept the position, and then you have some, yeah. Yeah.
you should go and have
Oh, yeah. Look like it, look like it.
Oh, fine. No, one.
Or I think they have one.
No.
Yeah, no.
Okay, fine.
Look like the artificial, the formal version. You know, like the.
Okay, fine.
What will be pretty much started about me. Because that's what I like. Yeah. Do you have a teacher? Can you ask for bring the one class after PPT? Yeah. That's what like the artificial. Yeah. No, you can bring the one in the way. Look like we be on the artificial. Oh yeah, do you have a magnificent like something like and how to say when you do the public exam for the online public exam, you have how can you teach it for the student? Yeah, anything. Yeah, can you bring it?
Yeah, we can bring one thing.
Can you? Yeah, that will be easy. Because we'll be so you may do like that.
So how do you go?
Bringing in our class. US dollar. US dollar.
1,000. Yeah, for the custom.
US dollar.
Yes, they can show they can
Then, for about $200.
US dollar.
Yeah.
But this is disposable. Disposable is possible.
Yeah. For single use.
Single use, but you like a risk for the similar transaction. Oh, it's there can be research for it doesn't have but they don't bring.
Yeah.
Only thing they can send it to the side. Big
Is there any panel? Okay, so where we go? I have a long time not to give a speech in English, so I have a lot of levels. This is our disposable electronic hysteroscope. Usually we usually let me say. Usually hysteroscopy and we use a operation group. But now we can use this at the authentication department because we have 4.9 diameter. And so we and it have our hysteroscope have 3 diameter
3 millimeter diameter turner. So we can use it to share, and code light is available on it. What it means, we can do some treatment and outpatient without any sterilization. But this is my first time to come to Malaysia for our company. So I didn't know is anybody any doctor who use code life and here. Is there any doctor use code life? No. No. Oh, this technique is popular in China. Okay.
So we're talking about the company made this for disposable laparoscopic. Not only can do diagnosis, but also very for treatment. So that means patient don't need to go to OR. They can do that just after they give you something like for surface sedation. That means the patient something like the benzodiazepine, also something maybe like hydromorphone IV. Then patient like not really have really general anesthesia. Then the treatment can be done at the outpatient or either like called day surgery in the clinic. So let's be, for example, if patient, young woman come to see the OBGYN, they have an unknown etiology of a normal uterine bleeding, or either like menstrual pain, or either like pelvic pain, then they can using this disposable laparoscopic can go in to take a look at the metriosis. Also can find out whether there's anything like polyp or either like anything like earlier like cancer or like then they can do biopsy. And at the same time, if they see some lesion, then they can do the resection and send to pathology. Then the patient can go in home in the next 2 to 3 hours. That's why patient don't need to go to the operation OT. In Malaysia, in Nepal, we call OT. But in North America, we call OR operation. We here call operative surgery. Okay, any question? Then you can try to solve the how to do it. Do you have a where's the baby right? So where's the medical? I borrow the medical, I can give it. I can solve the problem. Or you do not have that, right? Because we can make the like artificial uterine, that's why I can easy to thank you. Sorry for this. So you take off. Oh, but this is not it's not any version. Also, yeah. Let me show you. Yeah. You just yeah, you see here, I very good, you see, and very good imaging. I try to see here. So, for example, I use my palm to make the you can see. So this look like the vaginal wall. Then we go to the cervix. Then we go in. Then you can see the cervix. Now this is go to uterine, but I can try to see. So this is look like the uterine wall. So if something lesion or if something you can find out something abnormality, and you can either do the how can you do that? 要试过的如何去 take the biopsy， 如何去标本，就是说让你打过来，你把那个拿。So I'll be, for example, here is a lesion. Okay. So and 你把那个剪刀拿过来。
Can you use it?
哦，没带对吧？那就太大，没带对吧？ So, for example, let me show you. Can you hold it? Can you hold it? Can you hold this one? Yeah. Go in. Go in. So, for example, here is an
Yeah.
So, for example, if I see here, like here is something like a lesion. For example, if I see here is abnormality, something color, so they can do the go to biopsy. For example, like here lesion, then they have a very obvious. Yeah,
I think what he's trying to do is creating artificial
yeah,
women.
yeah, right. Then I go to this thing like cervical.
Because this equipment is used
Yeah,
as in the beginning. The women here mostly women. And this equipment, how they are utilizing for the robotic surgery, that's what he's trying to explain. Here.
So correct. So for example, here is a lesion, right? So you try to get biopsy, but he forget to put in the graph. So we can put in the graph go here. Thank you. Then go in. Then you can see something here. Then try to fit. Oh, okay. This is the picture.
That one is like this.
Okay. So for example, here is something like you find out something abnormal. Then you can put in the graph here. Then try to get a biopsy. And at the same time, they can have an electron counter line. If this is a polyp, they can remove the polyp. That's why I can do the treatment. Then the patient can go in home after the procedure in one hour to 2 hours. They don't need to be, get the patient completely general anesthesia to go to OT to do this procedure. This can be significant called a cost-effective treatment. Yeah. Okay. Yeah. Thank you. Okay. It will be so that I'm on. So you see, this is the image is high quality image.
首先啊，我首先要说一下，要翻译一下。
要搞一个好。
首先我介绍一下我自己，我是来自于中国福州的世普雷集团公司的董事长，我姓接，叫接业金。
Okay. This is Mr. Jie. Mr. Jie is the CEO of the Secret company from the Fuzhou, one of the Southeast Asia Chinese province.
非常荣幸的来到林肯大学，并跟林肯大学的学生还有我们老师们一起交流关于这个腔镜跟微创这个手术间设备以及你们的这个一些进展学术上的一些交流，并展示我们的设备。
It is my pleasure to be here in Lincoln University, and thank you for President, and thank you for your faculty and also students to let me to demonstrate my company equipment, especially in the minimally invasive surgery.
并且感谢校长。
And also, very pleasure to meet the president to discuss maybe possible future collaboration with the R&D here.
我简单的介绍一下我们公司。
I will be very briefly introduce about my company.
我们有4家工厂和1个互联网公司。
They have about total 4 factory, big factory, and also one, the internet company.
我们其中的1家工厂是中国的医疗脚轮及机器人脚轮的 number one.
Then one of their factories made the number 1 powerful wheelchair in the world.
并且为这个记忆公司、飞利浦公司、包括迈瑞公司、包括这个西门子公司提供这个轮子配套。
Okay, they stay on the the multiple biggest medical instrument company like Siemens and also GE and also Medtronic and also another one还有一家什么刚才提到是家GE 西门子
对我们的机器人的专用轮已经给5个公司跟这个2D公司提供配套。
Okay. So he have actually this all most of the biggest the medical instrument company in the world using their company wheel, power wheel.
对，我们第2家工厂是专门做移动医疗信息化的一些工作站的公司。
So the second factory he made the biggest like the platform to do the movable mobility called the workstation from the hospital. Like for example, they can move the platform, the station to go to different unit or different station to check the patient vital sign. Then also to save this, the patient vital sign on the lab information in the EMR called electronic medical record.
主要就是无纸化的移动护理、移动查房、送药跟远程会诊的一些移动车。
Okay, they also do the many like the telemedicine, do the something like the doctor can be using alert using this movable station to go to different patient, the bed to do the to quickly check the patient information.
我们第3家工厂是专注于老年人的这个健康产品的公司，主要有智能的轮椅、智能的代步，包括洗头机、洗澡机，还有一些适老化的一些设备。
So the third factory is most for geriatric care or like elderly patient care. For example, they're using the AI to to assist the elderly patient. For example, patient has dementia, how to take care of this dementia patient, how to using the powerful chair to prevention like senior patient can afford.
这家公司的产品现在能够实现这个自动驾驶，包括现在目前的整个医院的物流配送的输送。
So like the same as I mentioned earlier in the Toronto, this completely full digital hospital. So they have equipment can be using called artificial, like called AI, or just called robotic to deliver the equipment inside the geriatric center.
我们第4家工厂是专注于微创外科的手术设备的制造公司。
So the number 4 there he mentioned have total 4 factory. So the number 4 factory is most made minimally invasive surgical instrument.
我们的产品主要有这个内科的影像系统，包括这个超声刀，包括这个超声碎石。
Yeah, so they are most made the endoscopic imaging system. Also, they made a harmonic to cut and also using the also called and how the something like called treatment for the like kidney stone.
今天我们带来的产品主要是给大家介绍的是这种微创外科手术的一个设备。摆在我们下面的是超声刀以及光源机，包括4K 的内科镜摄像机。
So he will be so the very good one about the harmonic and also their imaging system and also their treatment system. They are actually in one system.
早上的时候有很多的我们的医生也介绍了关于微创外科的一些手术的视频，里面很重要的就是在进行手术的时候需要这个内科镜的摄像机来帮助他看那个腔内的一些组织。
So the very important for the minimally invasive surgery that the surgeon can be easy to get a good imaging, especially in the monitor. They can get a high quality resolution imaging. That's why the doctor can easy to detect the lesion, can do the that's very important. If you have to be a good surgeon, number one, you need good exposure.
早期的时候的内科镜从1个 CCD 到3个 CCD， 到现在目前的4K 或者CMOS 的这种数字化，已经有很大的一个变化。
So in the last several centuries, the minimally invasive gynecology surgical imaging system have been significantly developing. Now have go to the 4K system is very high, solution for the imaging.
包括技能目前也在逐步的推广的3D 的影像。
Also have 3D, imaging. Mr. Jie, he is not only CEO, he's also very good designer. He have a master PhD degree in the imaging, designer.
我们现在的这个4K 的摄像机的这个 CCD 上面的话，可以进行图像的5倍的放大。
Okay, so his imaging system, using this can be about 5 times magnetic for the picture. Actually, Dr. Payapasi using his instrument to do the 2 surgery in the car. He thinking about this system maybe more better than GE than the Olympus.
然后同时的话，可以实现这个冻结图像。
And then they can be frozen, you see, keep the image frozen.
所以都还可以校正在腔内的时候的图像失真的一个色彩还原。
They can be also correcting, sometimes they have imaging loops that, like truly, like image.
还可以控制进行图像的录制。
They also can record the whole operation recording.
所以这个目前的手术里面的操作会变得非常简单。
Next, we made a surgeon to do the surgical dissection, resection for the lesion, and surgery very easy.
这个是一个分体式的一个内部镜的一个设备。
So this can be actually the part can be separation.
然后这个镜子可以旋转。
They can also rotation for the trocar also.
然后目前的话，这种一体化的内部镜也有很多。
Yeah.
好，那我们这个就先不讲了。
可以演示一下哦，没办法演示。
哪个？
没办法演示一下是吧？
有啊，
已经OK，
你看到了是吧？
Yeah. It is very clear. It's
清晰吧？
And also they have magnetic for about 5 times. 它放大5倍的，你看。
刚才已经放过了。
Magnified, but also very clear. And also then naturally it's so simple to say then a surgeon can be easily then the surgical be good exposure.
摄像机的好坏主要取决于，首先第一个的话是它的清晰度，第二个的话是它色彩还原。
So the most important, the good camera, number one, and then the picture very clear.
第三个的话是它在遇到这强光的时候，里面使出器械回反光。
Yes. Inside organ, magnifying inside the organ more clear and more better.
Yeah.
So if I may understand now what you are trying to present, that when a surgeon want to operate, or surgeon want to do any kind of operation, most important, he or she, the surgeon, must view very clearly and be enlarged with. Am I correct? Am I correct?
Yes.
This is what is this most benign equipment is all about. In spite of going inside, so outside you are trying to show this particular cell. Probably you understand, but trying to say you are a surgeon, you can explain to details. I'm not a surgeon, but yeah, I'm a surgeon anyway. Thank you.
Thank you, Dr. This is a beautiful camera, in fact, because it has good resolution.
By the way, let's see.
Understand? Prof. Walid is our Deputy Dean of Clinical Experiments. So he, and by profession, he has been a surgeon as well.
他是这位医生是这边的医学的副院长，也是外科医生出身的。
So that's why he will be able to explain now. But I understood in layman terminology that's not the next.
他是院长说他虽然不是外科，但他讲的还
The camera, of course,
把它放大。
is high definition camera. You are all familiar with high definition camera. When you buy your mobiles, when you buy your screen. So this is something very good. The other thing about magnification, this scope will go into the abdominal cavity. And there are two ways to gain magnification. Either by pushing the scope closer to the structure. But this camera, so the image becomes bigger. But sometimes when you get very close to the structure, then your working field is obstructed. So what this camera has, by a press of a button in the handle, you can enlarge the image without getting near to the structure. So, yeah, this is what they want me to explain to you, but I'm not sure if we're getting it. So you got my point? You can enlarge by pushing the scope nearer. And you can remain at the same distance, but at the same time you are swimming. Okay? So the surgeon can see the very minute details, okay? Because visibility is the most important thing. At the time of open surgery, we used to make big incisions to have good exposure and visibility. When we now do laparoscopic procedures, our eyes is carried with this device. So instead of opening the abdomen, the surgeon eye is moved from here to here. And this gives the light because inside the abdomen is dark. Without the light, you cannot see. If you go into a dark room, you cannot see anything. Although you have a camera, you take a photo, nothing comes. So you need a light source. And the light source is transmitted through this cable here. And the light source initially used to be made of xenon lights, old. I assume this is halogen, sorry, the old one is halogen, this is xenon, isn't it? So this is xenon. Xenon. Must be xenon. Because I look at it, and when you put your hand on it, it doesn't produce any heat, which is a very nice feature, because the halogen used to get hot.
Is it cold?
This is cold.
Oh, yeah.
So when you have hot objects, and usually the surgeon does not hold the camera, the assistant will hold the camera. If he gets very close to the bowel, the heat from the light can injure the bowel, can do a bowel injury.
That is what Bizan was telling me, sir,
Yeah.
this money will burn.
Yes.
And Samira Khala said, no, I will give you the money.
No, not with this one, but it's safe. It is called light. It is called light source. Okay. So the basic equipment to do any laparoscopic surgery, you need a camera and processor of the camera. You need the scope. You need a light source. Okay, and they usually have, I believe you have insufflator also. And then what you use in your hand is called instruments. All right. With this, you can do any kind of surgery inside the abdomen, whether it is on the stomach, on the liver, on the gallbladder, or down in the pelvis, or doing hysterectomy, oophorectomy, whatever it is. The basic equipments are the same. Now this one, it's not a zero view. It is, I think, 45 degrees, 60 degrees. Looks like 62. 30. Yeah, because the light is too bright. So you don't see.
30
Yeah. So this is a good when you use a camera that ends like this. We call it zero view. So zero view is you can only see straight, but when the tip of the scope is kipped, angled like this, when you put it like that, you can see with wider angle up. So this helps very good in pelvic procedures, in gynecology. In general surgery, we normally go for the zero. Okay, but for the pelvic procedures, it's good to have the 30 degree.
So that goes into the uterus.
No, this one will not go into uterus.
So it's not a
This is inside the peritoneal cavity, inside the abdomen.
So it's not a
The first one, where is another one?
This one goes to
Yeah.
uterus. I think
This one is hysteroscope.
goes to
It is disposable.
Yeah. This one.
They have made it disposable, so you save the time of washing, sterilization, chances of transmitting disease and viruses from one woman to another. So this would be thrown after use, single use.
Yeah.
Okay? Yeah, single.
But some maybe developing country, they can still sterilize.
Yeah, they re-sterilize until it is completely
Because
complete.
it will cost.
Yes, we all do that. Yeah.
But you are okay.
Yeah.
Sterilize.
I believe the scope is autoclavable.
Yeah.
Okay, it is autoclavable because the older generation has to be immersed in glottal-aldehyde. And glottal-aldehyde is toxic to the staff. Okay, the nurses who work repeatedly on these disinfectants, they get asthmatic, they get breathing problems. So now our good engineers, they made these designs that you can autoclave like any surgical instrument, not the camera, of course, but this one. Usually the camera is covered with a plastic, sheet that comes single use. All right. Yeah. So, anything else to say?
It's wonderful. Yeah.
No, he did very well.
He always had go to OP.
Yeah.
Follow
Yeah.
the surgeon from beginning to finish.
Very good.
That's why he know what's happened.
Yes.
How to do good design. 我说你因为他这个教授非常好，他是外科医生出身的，做了很多相信他自己的力很懂，他是非常好的。是因为我告诉他，你几百开手术都跟着外科医生去看，知道他们需要什么，知道他们。
Okay, they have this camera and they have this slide.
Yeah.
What about the instrument? They have
Do you-
the robotic is different.
No, wait. Do you have the shears, the blasters? Do you have a line?
Oh, 没有，这个是这个吧？
Do you have a line of instruments? Okay. So harmonic scalpel. The harmonic scalpel I know is it's produced by Ethical. I use that.
Yeah, but this is
So,
made by themselves.
This is made by your company. This harmonic scalpel is one of we call it electrosurgical device. So what we mean by electrosurgical device, sometimes during dissection, you have to cut tissue, but without causing bleeding. So when we use ordinary scissors can cut, but also will cut blood vessels, and you will have a blood. This device will cut, okay?
This is what this is about burning this.
Yeah, this one will burn, because this is designed to burn. Okay, you see now, it has come through here, and usually, it's okay. I just wanted to check whether it gets hot or not. So this one, is it ultrasonic? Not ultrasonic.
ultrasonic.
Not ultrasonic.
Ultrasonic. Yes.
Is it ultrasonic? Because ultrasonic does not get very much. Ultrasonic. So let me explain to you, because there are two ways to do this. You have the line of ligature and the line of ultrasonic scalpel or harmonic scalpel. So this one gives ultrasonic waves. Ultrasonic waves shake the molecules inside the tissues. You know, by shaking them, by vibrating them, you generate heat. Like when you get cold, what you do like that in cold weather. So this friction and movement leads to heat generation. So the same thing between the two jaws of this instrument, the heat is generated, and the heat will coagulate the protein, because protein starts to coagulate. Anyone knows? At what degree? When you boil egg. At what degree the protein in the egg starts to coagulate? 60 degrees. Okay, 60. So all our cells, the tissues, contain protein. So when you heat the protein, it will coagulate, and the blood has protein. So the blood vessels will be clogged and closed. And in this way, the surgeon can cut through the tissues without causing any bleeding. Usually, what we can cut are the vessels which are less than 3 millimeters. Bigger than 3 millimeters is not safe. You have to put clips. Okay? So anything 3 millimeters, is that correct? 5 millimeters. Oh, that's excellent.
So you say this one is about 55,000 per ultrasound.
Yeah, but can it close a vessel in 5 millimeters diameter?
5 millimeter. Anyone less than 5 millimeter.
Good. So previously the equipment I work is up to 3 millimeters. In larger, you need to put in a plate. Plate is just comes like a vision, and then you close it.
So we're using this one, the day before yesterday, National Hospital using this equipment.
Very good. Very good.
It's very good tonight.
This comes as 5 millimeter and 10 millimeters, or just 5 millimeters. Okay, this one is for open surgery. Same principles. Okay, we use this one. It's very good. And again, for the same principle, instead of cutting with scissors, so we heat tissues, coagulate them, and then finally we work our way in dissection.
So what we see, whatever can bring this kind of equipment here, or president with you.
Hopefully.
And R&D, they can be very good to be serving here.
Okay, I'm ready to help.
Thank you.
Okay, thank you for that. I hope I was able to make it clear to you, to explain the principles, how these.
Very good, very good.
So you got instant consultant.
Yeah. 你这边已经给你找到一个最好的外科医生做我的顾问。
我就表白态度，我们希望送一套给他们做照顾。
So the president, CEO said you will be giving this one equipment for donation to the university for teaching the students.
You say, I think, hold on. For this, we must congratulate him because he understood.
Yeah,
Thank you, sir. You are coming over as well. Come, please, come.
You will maybe feel the modern OP one. Okay.
Okay. All right, take photograph. Prof. Walid.
They want.
Okay. Okay.
Yes.
Huh?
You do like going on?
That's very good. So we'll be getting this one to university for teaching for students.
So, yes, yes.
Yeah, we'll be giving this one. Yes, I will do my about. Yeah.
A training box.
对于我们非常愿意跟学校来一起。
To use, we need a training box.
对我哦，你们原去boss，你们那个那个去哦，就在我那边在。
OK OK， no problem。
我
I promise you all, before you graduate, every one of you will be trained on laparoscopic surgery.
正接的这个训练的这个东西，让这边这个大学的所有的医学生等他毕业了都会成为一个非常好的微创外科医生的。
是的。
Okay, another thing. If we do that, and hopefully we will do it, you will be the first medical student who gets training on the laparoscopic surgery.
深做微创训练的大学。
非常好。
Usually this training is offered only for postgraduates. But for undergraduates, I have not heard of any university that provides laparoscopic training, and on a simulator that I requested, that for the undergraduate students, okay?
Yeah,
So,
even in America, Canada, I don't really be.
they don't. We are the first medical school to start.
整个世界上为数多的能够让医学院学生就能到的接触创外科，太厉害了。We will be getting a news report。
那个副院长，
他很喜欢你，你 say like you。
Thank you. Thank you for your generosity.
Very good teacher. Could be teaching.
I'm proud of him.
Very good, very good. Easy, easy understand. Yeah.
Okay. Thank you.
He has to be because he has to take a back. Okay.
Thank you.
Thank you. Okay. Now you
Yes,
have
yes.
some questions.
Yes,
So now Prof. Walid can answer the question. Okay, quick, because he has to leave in 10 minutes. Okay.
Thank you, Mr. Ji Yoon Bi.
One second. Professor Pius could not be here this afternoon because he had a very, very bad jet lag. So we couldn't do hotel, let him sleep. But Prof. Walid will replace him. If you have any question, Prof. Walid has understood.
Yeah.
And
where you come from? You just tell that you go.
no, we have not he. Our Prof. Pius.
Oh, that's my idea. Okay.
He is from our Kotabaru Clinical Teaching Center. Okay, so let's have a question and see what happens.
Okay.
Walid, you see what you can answer.
Okay, you know, all I'm not gynecologist, okay, but believe me, I usually take the uterus out in 10 minutes. When I do my colorectal surgery, sometimes I do restrictive, extension of the tumor to the uterus. So hopefully I can answer some of your questions, but I'm not a gynecologist, okay? Yeah, right. So any questions related to Prof. Ersad? Prof. Ersad's presentation.
Okay, dear students, can you please ask your questions to
If you
Prof.
have
Wali?
questions,
Yes.
You don't have any question, you as such in written.
Written, Prof. Written. They will give the questions to Prof. Wali.
So very quickly, yeah.
Good afternoon, Prof. I'm from Tier 2 Medical Faculty. What are the rules of nanotechnology in surgery and infection?
very big question. Thank you. The technology has helped us a lot. Without our colleague engineers, we couldn't have progressed with our surgery. They are the soldiers who made our life easy and made our procedures successful. Without these devices, without the electronic engineers, without their talent, we wouldn't have gone into this stage, of course. So surgeons usually meet the engineers and work together. They tell them what they want, and they will do for us what we need. And both together, we can improve the life of our society. We can treat most of the diseases. We can prolong the patient's life. And when we cannot prolong their life, at least we make them less, suffering less, okay? So we improve their quality. So the technology is advancing so quickly. It's so quick. Let me tell you, I was telling Prof. Imad about things not related to ONG, but general surgery. You know that you can, everybody knows when you have to remove a thyroid, you have to do an incision in the neck. So people were not happy, especially the young ladies, to have a scar in the neck. So the endocrine surgeons said, why don't we try like our, abdominal surgery, and we do it also by little keyholes. So they started doing a keyhole surgery, making 3 or 4 incisions in the neck to remove a thyroid problem. After the endocrine surgeons gained some experience, they said, oh, we are not happy about these little scars here. So one of the surgeons came with a fantastic way of removing thyroid by doing the incision behind the ear, and going all the way under the skin to remove the thyroid. Another one came with a different technique. He made the incision between the lips and the gum. So he goes all the way down under the skin to remove the thyroid. Another one said, oh, this one can carry infection because the mouth is not sterile. So why don't we go from under the breast? We go under the breast and we work our way up to the neck and remove the thyroid. So this is how the endoscopic surgery is evolving. Now you may tell me, is this applicable everywhere? I would say no. But this is a kind of surgical fantasia. It is a challenge. The human nature likes the challenge. always wants to bring something new, always wants to add something to the literature. And this is how we in our medical school, we try to put this spirit in the student minds. Come up with something new, search the literature, read about the new things that I do not know, and you come and discuss with me. In this way, you develop yourself. And so the surgery is developed in this way. Okay? Sorry for my
How we keep PIE integrate and endometriosis in possible open surgery?
Yeah, of course. Of course. Endometriosis is a very difficult disease to control. You know, everywhere those ladies, unfortunately, they get exposed to several surgeries 3-4 times sometimes.
Also, some of the lower level of cancer.
Yeah.
Now using the laparoscopic minimally can steer the kidney or anus.
Thank you.
Thank you. Very good.
I think we finished properly because it's leaving question. So there is one question from the audience about, you mentioned in your picture about the risk of laparoscopy. So there is what cases are in which we have this one. For example, what the risk when we use laparoscopy?
Okay. If the person who is asking referring to the risk of laparoscopy in trauma, I believe, I put the risk or summarize the risk as following. Number one is that if there is a large vein is open inside, when we inflate gas, we usually use CO2 gas, this might lead to gas embolism. So we have to be careful in traumatic cases. Okay? Next is patients who have diaphragmatic injury. When we inflate the abdomen to a high pressure, which sometimes go up to 15 millimeters of mercury, this will escape because the diaphragm is ruptured. The gas will escape to around the lungs and cause tension pneumothorax. So the lung will collapse. So this is another complication that can be seen in this kind of surgery. Another one, when there is head injury and there is raised intracranial pressure, because the patients may come with multiple trauma, polytrauma, we call them polytrauma victims. So we have to be careful about those to insufflate. We can do laparoscopy with low pressure. We can go with slow insufflation. Once we see the diaphragm is, injured, and we can see the lungs from the abdomen, then we have to stop insufflation because this will cause fatal pneumothorax. It will not be fatal, maybe the anesthetist is around so they can overcome, but it is a troublesome and complication. So these are the main things that every person has to be aware about when he has to apply laparoscopy in blunt injury of the abdomen.
Yeah, I think the last one very important. If you like to be the group laparoscopy surgeon, you should be at the open surgery surgeon. Otherwise you fail on the laparoscopy. You don't know how to open surgery. Thank you.
Thank you.
You have to go.
I have to go, yes. Okay. I have enjoyed being with you all. Thank you, my staff and colleagues from the Faculty of Medicine, students, and the company members. To be here with you. You have given me a very good day today. Thank you.
Thank you.
Yeah, that's
Thank you, Mr. Ji Yunbi, CEO of Secure Medical China, Mr. William Ju, Mr. Leo Dongson. Okay, thank you, Prof. Walid, for the detailed explanation and assuring our students to be trained in the laparoscopic equipment. Thank you, Dr. Amia, for arranging such a lovely and lively session, which would definitely motivate our medical students to become a highly competent doctors, which is a part of our mission and vision. Okay, thank you very much. Now, Prof. Walid will leave, but we will continue the question and answer sessions. Okay. Now we will continue because there are few more questions. So,
Question from the audience for Dr. Song about the laparoscopy advantage, because you mentioned during your speech about the advantage of, so if you can summarize the advantage of laparoscopy.
So I think the major advantage from the lab minimally surgery is number one. Incision can be getting very small. That's why decreasing the pain and also the time the patient to stay in the hospital, and also definitely another one is do cosmetic, because in the normal now, if you do the minimally invasive surgery, they only do the four, trocar small trocar is less than about 1 centimeter. But if you do that, for example, do big surgery before 20 years ago, 10 years ago, if you do the open surgery, if you do hysterectomy, if from incision and lead under the, normal upper mid, the chest, mid upper abdominal wall down to maybe the above the pubic. So that's why it's very long incision. But laparoscopy surgery only very small for the trunk and then for cosmetic. Number two, I think the major for decreasing the pain because incision is smaller, and that's why patient will not too much painful. Number three, I think the time the patient to stay in the hospital recovery will be significant short than traditional open surgery. That's the three major. And also another one, I think also can let the bleeding compared with the open surgery. That's the four advantage for the minimally invasive.
Okay, thank you very much. Thank you, Prof. There is another question also about there is some certain surgery we cannot do it with the laparoscope. For example, like cancer.
Okay.
When we do surgery of cancer, for example, from inside, we have to remove all, for example, cancer in the area. But with the laparoscopy, we cannot see it. So maybe if there's any part of this cancer remaining, so it will do. So this is one of the cases, but maybe more.
I see, I understand. So this is wonderful question. Actually, the laparoscopy surgery is actually can see more better small lesion on the metastasis compared with the open surgery. For example, if you have cancer in the pelvic, under the pelvic, because you understand the space of the pelvic is very narrow, very small. So if you do open surgery, you cannot see very well. But if you're using a laparoscopy, then they can magnify the surgical view. Then you can see the lesion well. Number three, now have a called robotic surgery, because in the before we using the laparoscopy, using the scope camera go in, the scope is cannot movable. But if you're using the robotic, because robotic do like the human hand toenail can be very good, like different angle can angle can movable and easy see the lesion. But the major reason if you do the laparoscopy surgery, if it's cancer, so in case you put in the trocar go in, then you try to remove the tumor, or they can be go to metastatic, it will go to the visceral, can go to the intra-abdominal wall. So sometimes the cancer need to be open surgery, because number one, they can do the radical to resection the complete tumor. On the same time, they can do the lymphadenectomy, because if something have a tumor metastasis to the liver or to the lymph node, they can remove that. Laparoscopy have a something limitation, cannot completely remove all the different. So it need to be depend on your surgeon experience. Also depend on the surgeon have any capability to do this. Number two, you need to be thinking about if I using laparoscopy, sometimes you remove the tumor, they can be also maintained to the the intra-abdominal gap.
Okay, thank you very much. Thank you. There is one question about the robot surgery. Do the robot surgery can replace the medical doctor like what we see now? The robot replacing, for example, for different field. Do they can in the future? I mean, we see medical doctor but robot.
I think
We don't need medical doctor.
that's another very good question. Actually, initial robotic surgery is not meant to do the minimally invasive surgery. Initial robotic surgery is because it's LASA, the American Nasal and National and Astronaut, and council, and they worry about if they, the station, they go to, like they go to the space. So if they get an astronaut, they have a PC, for example, they get an acute appendicitis, they have no surgery there. So they think that surgeon can be stay on the earth. They're using the list robotic. That means surgeon don't need to go to the spaceship. Then they can do the surgery. This is the major initially design on robotic. But finally, they find out robotic because I mentioned they have like human hand can go inside intra-abdominal, intra-chest, or especially inside the pelvic, can easy to move surgery. That's why now robotic surgery is very, very popular now to then a young surgeon because they are easy learning compared with the laparoscopy surgery, easy learning compared with the open surgery. So it's very, the trend is, I was told, I'm not doing the surgery now, I'm doing emergent medicine, but I did do cardio surgery training. They also using robotic surgery, but they need to be understand. If you like to be a good robotic surgery, you should be to do the very good to open surgery first, because it's not mean that you do any robotic surgery, you can do any kind of the theory or any kind of disease. So in case you go there, sometimes you have deep breathing, you cannot stop breathing, you have no choice. Sometimes you still need to be called the open surgery during the robotic procedure. So it's not me, it's not me you do robotic surgery, then you can apply to any kind of the surgical condition. You should be training to be a open general surgeon first, or even a woman surgeon. Then you can learn to do the robotic surgery.
Thank you very much. Thank you. I think we will end the session and because of the time.
I want to add, what your last question is: robotic surgery will replace the money.
Yeah.
Let me Prof, can I say something? During COVID, during COVID, we can't go to the clinic. So they close all the clinic only by phone. We can ask, for example, the doctor, and he reply and he give you for example.
That means good.
But only for
Let me tell you, whatever robotic is doing, robotic is not doing anything.
Yes.
Robotic is doing what human beings is currently doing. In other words, the robotic technology is helping human beings to innovate, to discover new ideas, so that these robotics eventually can pick up that new idea. So I beg to differ that robotic is going to replace. So I don't agree on that. But rather, robotic is pushing the medical doctor to think, to innovate, to discover new things instead of depending on simple, basic what is going on.
That's most important. And that's why I like robotic, because when we all can think more advanced level, more we can practice more ways. Recently in Hollywood, in USA, the Hollywood writer, those who write movies, they called for strike because movie producers, they are using artificial intelligence. But I turn around, these writers shouldn't be worried. They should be thinking more smarter AI, but instead going and fighting. The businessman or the running person, I'm running in Lincoln University, I have to think finance. If you faculty member do not deliver what I want, I will deploy AI, get lost. It's very simple, because by employing you, I don't have many students, I cannot get the tuition fees, and I cannot pay you salary. Your salary is very high, and the students cannot pay the fees, that high fees as well. So what I will do? I'll say, get our faculty member, I will use AI report. But this is all about. This machine is all about this. You go to hospital, a simple surgery will cost you $10,000, $20,000. Because the human being, they demand salary. Why? Because they think they cannot be replaced. That's why these robots come into play. So I beg to differ, because when the human being, they think, when they have a knowledge, oh, they are like God. Nobody can throw them out. And I love this technology. Get out. All those called egoistic human beings. Get out the egoistic human being and get people who are down to earth. That's why the robot is helping the human being must think in more advanced knowledge rather than simply depending on little thing. Clear your answer? So if anybody says robot is replaced, that means they are worried for their job. And I will say, I will deploy more AI robot so that I want to chase out this egoistic people around. Thank you very much.
I can ask one. No matter any kind of AI, our human being brain is more advanced than. So the human being try to keep going. We try to get any kind of innovation, try to let our surgery do easy, surgery do more quickly. And remember the last one, safety, and a very good patient outcome. Everything try to do this like this.
Thank you very much. Thank you.
Thank you so. Thank you so much, Professor Prof. Abdullah and Prof. Abhinay, also our speakers for today. So to all participants, and as we embark on this enlightening journey, let us keep in mind the immense impact of laparoscopic and robotic surgery have had on the medical world. With each passing day, these advancements are redefining the surgical precision, patient recovery, and overall healthcare outcomes. Without further ado, I would like to call upon Yang Berbahagia, Professor Dr. Hajab Victorina Abdullah, to give a closing speech for our ceremony. Please.
Thank you, Amel. Bismillahirrahmanirrahim. Assalamualaikum. And I see everybody is still active, yeah. To our president, Professor Dr. Amia, and Datin is here, and all top management, and of course all the participants this afternoon. So as we come to the close of this remarkable one-day seminar on advances in laparoscopy and robotic surgery, I stand before you to thank the Faculty of Medicine at the Lincoln University College. So I also like to thank all the delegates to express my deepest gratitude and admiration for the insightful discussions I was informed and innovative ideas and invaluable experiences as we have shared today. This seminar has been a testament to the ever-evolving field of laparoscopy and robotic surgery, which has transformed the landscape of urology and also gynecology. We have witnessed firsthand the incredible progress made in minimally invasive techniques, enhancing patient care and improving the surgical outcomes. Today, we have explored groundbreaking innovations and scientific advances that have pushed the boundaries of what we thought was possible in these fields. So throughout the day, we have had the privilege of learning from distinguished experts who have dedicated their lives to mastering and advancing these surgical techniques. Your expertise, coupled with your passion for research and patient care, has inspired us all and instilled in us a renewed sense of purpose. We have been enlightened by your presentations, your case studies, and live demonstrations, leaving us with a wealth of knowledge to take back to our respective practices. So this seminar has also provided us with a platform for fruitful networking and collaboration. We have had the opportunity to engage with fellow medical professionals, sharing ideas, experiences, and best practices. So the discussions and interactions that have been taken place here today will undoubtedly pave the way for future collaborations and research endeavors. Together, we can continue to push the boundaries of what is possible in laparoscopic and also robotic surgery and revolutionize patient care, especially in urology and gynecology. As we conclude this seminar, it is important to acknowledge the immense effort put forth by the organizing committee actually, and also all the speakers, and all those involved in bringing this event to fruition. Your dedication and commitment to advancing medical knowledge have made this seminar a resounding success. Let us extend our sincere appreciation to each and every one of them for their hard work and unwavering support. Finally, I would like to express my deepest gratitude to all of you, esteemed delegates, for your active participation and enthusiastic engagement throughout the day. Your presence has enriched this seminar, and your contributions have made it an unforgettable experience. Together, we have created a vibrant atmosphere of learning, collaborations, and growth, which will undoubtedly have a lasting impact on our respective medical practices. As we depart from this seminar, let us carry with us the knowledge we have gained, the connections we have made, and the inspiration we have felt. Let us apply what we have learned to our daily practices, always striving to provide the best possible care to our patients. Remember that our collective efforts, fueled by continuous education and innovation, have the power to shape the future of laparoscopic and robotic surgery and transform the lives of countless individuals. I would also like to express, I was just being informed, Dr. Ji Yun Bing. Yeah. You have from Medical British Columbia, Canada, is it? And you are the CEO of Sacred Medical China for your donation to the medical faculty. Thank you very much. Thank you very much. You really appreciate it. Thank you once again for your unwavering dedication to the pursuit of medical excellence, and I wish all safe travels and continued success in your professional endeavors. May we meet again in the near future, sharing future breakthroughs and celebrating the remarkable advancement in our field. So thank you and have a good day.
Next, we would like to continue our event with a token of appreciation. I would like to invite again Yang Berbahagia Dato' Hajat Farina Abdullah and Professor Dr. Amir Bomik, okay, to come in front to give the token of appreciation to our speakers. Please welcome Dato'. We would like to start off with Professor Dr. Resat Pasik, but it will be received by Associate Professor Dr. Sandeep Shrestha. Next, I would like to invite Associate Professor Dr. Sandeep Shrestha, Associate Professor Kikihar Medical University, China, to receive the token of appreciation for Nipah College. Also, I would like to invite Dr. Jian Ning Song, owner of Megapol Medical. Please welcome Mr. Dawson Liu, Overseas Sales Director of Human Biomedical Technology. Mr. William Y. Dongju, Director of Polygon Health Center, Canada. Please welcome. And finally, Mr. Ji Yungbing, the CEO of Secure Medical China. I would like to call for our PhD of medical students to receive their certificate for today's event. Please welcome Ji Hui. Please welcome Ms. Li Xingmei. Next, Yao Hongbo. Next, please welcome Chi Li Quinn. Please welcome Zoom Wan. All right. Next, please welcome Wang Zizhou. Finally, please welcome Pang Chi. Thank you so much. So, Alhamdulillah, we have finally up to end of our event for today. Thank you so much to all speakers, and great gratitude we should give to all. Big applause to our speakers for today. I would like to thank you for all the committee members who have made this event successfully. Thank you so much once again to all speakers. Thank you again, and appreciate all of your time. And I really hope all our participants had a really good time for today's event. Yes.
Applause, give applause to Dr. Ali, who has made a real contribution and impact.
You all will please make a very good. Thank you so much for watching this online.
No. Just left.
I mean, to watch it online? No, maybe not. Okay. So I think that's all for today. Thank you so much, everyone. Thank you for your time again. And I'll see you soon. Hopefully. Thank you.
Can you move this one?
Okay, can I have another group photo session once again? Okay, I think we start off with the speakers and all the Dr. VP as well as Professor. Oh, okay. Okay, I think we're gonna take it from here. Okay, I need all the participants and everyone.